Hello and welcome everybody to the ENT update for the primary care provider in 2021. My name is Dr. Adam Cassis. I'm a physician in Valley ENT, and it's my pleasure to present to you this conference this morning to update everybody, you listening and streaming at home, for our yearly update for the primary care provider. So first off, a list of thank yous. Of course, number one, Lisa Altman, could not have done it without her. She's the glue that's been keeping this ship together. Also, Dr. Ryan Rehl, who originally organized this conference. This is now our fifth ENT update, first started in 2017. So many thanks to Dr. Rehl for his guidance and previous organizational efforts. Also, would like to recognize Dr. Dan Hurley, current president of Valley ENT, for his help organizing this conference as well. Also, Michelle Smith, CEO of Idlewild Advertising. She's been tireless in getting the word out about this conference. We're really trying to reach as many folks as we can to help improve the care of our patients in the community regarding ENT problems. And so her efforts in this have been very well regarded. Also, Denise Gullickson and Deborah Schneider from HonorHealth from their CME office. There's a lot of requirements that go into organizing an event such as this. Also, the presenters, everybody from Valley ENT who's going to be speaking today. And of course, you, the attendee at home. This is the reason why we're doing the conference, to help educate you. Obviously, you've recognized that there's a need to attend this conference to better take care of your patients. So again, let me thank you for being here today with us. So this is our disclosure slide. This CME event is not supported by any commercial entity. As far as disclosures, Dr. Jordan Weiner disclosed that he is a consultant with Inspire Medical Systems. All other speakers and all members of the planning committee have no relevant financial relationships with a commercial interest to disclose. There's 4 CME credits going along with this conference today with the Arizona Medical Association, with HonorHealth and Valley ENT. So the course syllabus is online. It's in PDF format, includes all the bios for speakers today, as well as all the slides from all the presentations. So look out for that. You can refer to that after the conference is complete and watch during and as we go along. Again, CME requirements, there's 4 credits, Category 1 credits today. Please sign in to the chat box below on the video. That's how we'll know that you're attending, and we can also make sure that that email address is valid. That's where the link for your CME course credit will go out to. Please also remember to fill out your course evaluation. You have to fill out the evaluation in order to receive credit for this course. After about 30 days, you can contact the CME office at HonorHealth, and they will email you your transcript. So why should we provide an ENT update? So otolaryngology is a field that's rapidly making advancements in our care and technology. So that requires us as practitioners within this field constant attention, not only through self-education, but also conference attendance and other means to stay at the forefront of these changes. And we do that to better take care of our patients. How then would somebody on the front line, you folks at home, be able to keep up with these changes? Given that you're dealing with all different other sorts of medical fields and medical problems. So the ENT update allows us to review these problems most salient to your care setting. So what we do is we'll distill out the highest yield on topics that allow for optimal care of patients with ENT problems, and then help you determine when referral may be necessary. Of all the problems that patients come into the primary care office to be evaluated for, about 30% of those are related to problems in the head and neck, and this is up to about half in a pediatric practice. So the majority of the patients coming into your practice are going to have ENT complaints. But there's 3 opportunities for education within ENT topics, and we'll see that these opportunities may not be fulfilled as well as we would like. So the first opportunity is going to be wherever you had your medical training, medical school, so forth and so on. There was a recent survey that looked at medical schools, and only a minority of medical schools had a compulsory ENT rotation or skills testing. The second opportunity is going to be in your residency or any type of postgraduate training. Again, another recent survey that was conducted found that 75% of family medical trainees had very little formal ENT clinic instruction. So finally, that leaves us with CME events. So we feel as otolaryngologists in the community and as Valley ENT that it is our duty to really reach out and educate the medical community on changes within our field. And we're hoping that through this collaborative effort, through this ENT update, and continuing relationships, that we can make better care for our patients together. So a couple studies I'd like to briefly go over before we start our conference to further drive home this message. So this is a survey that was sent out to multiple specialties, multiple different training levels through primary care. And this is a survey that was given out prior to an ENT update conference, much like we're giving today. So 12 multiple choice questions. Those practitioners' average score was 4 out of 12, and these were questions geared towards the primary care provider. So you would hope that that score would be 10 or greater, but it's 4 average. Also, at the end of that conference, 91% of the attendees said that they would attend a conference like this again, and the majority suggested a yearly update. This is a tabulation of those scores. Again, you can see it all averages around 4 per specialty. Family medicine is a little bit higher than most, but no significant difference between those 4 different categories. Likewise, another study that was recently completed looking at otolaryngology knowledge among primary care trainees. There was 3 groups that they tested. One was ENT residents, the second was 4th-year medical students, and third was primary care residents, and this is any level of training. The average scores for ENT residents was 93%, all others 56%. What they found was that 4th-year medical students, there was no score difference between the 4th-year students and primary care residents of any year of training. So basically what this tells us is that beyond medical school, there's little, if any, education within otolaryngology. Only 16% of primary care providers and students felt that they were comfortable treating these conditions, and that 86% desired increased education on these topics. So our learning objectives today are a few things. One is to address these knowledge gaps that we know exist. 2 is to update the learner, attendees on new technology treatments and the clinical practice guidelines that are published by our academy every year. And finally, to apply any evidence-based treatment of ENT problems to improve patient outcomes. So the agenda today, we have 8 different discussions. Each discussion time slot is about a half an hour long. The talks will be between 20 to 25 minutes, which allows for about 5 to 10 minutes of Q&A at the end of each discussion. So please ask your questions in the chat box below, and we'll be able to address your particular concerns on each topic. So the topics today we'll first start off with healthy aging and hearing loss, myths of sinus surgery, obstructive sleep apnea, skin cancer in the head and neck. We'll have a short break of a half an hour. And then in the second session, we'll have talk about nasal obstruction, otolaryngic manifestations of COVID, dizziness and vestibular physical therapy, and finally, sudden sensorineural hearing loss. And after that, we'll adjourn our conference. Today will be Dr. Madeline Frangenberg and Dr. Calla. They will be discussing healthy aging and hearing loss. They are both comprehensive otolaryngologists within our Arizona Hearing and Balance Division. They both also specialize in cochlear implant evaluations and programming. So with that, I'd like to welcome our first 2 presenters to the podium today.
Good morning, everyone, and thank you for joining us. My name is Madeline Frangenberg, and I'm joined here by Calla. We are both audiologists at Arizona Hearing and Balance Center. We work with Dr. Cassis and Dr. Fucci, and we provide comprehensive hearing services to children as well as adults. As audiologists, we do diagnostic testing, consultations, and fittings for hearing aids, cochlear implants, and bone-anchored hearing devices. And today we're going to be talking to you about healthy aging and hearing.
So just that disclosure agreement again, that was read off by Dr. Cassis. So our learning objectives today for this presentation, by the end of this presentation, we are hoping that you will be able to identify the risk factors and possible causes of hearing loss in adults, recognize the consequences of hearing loss in older adults, as well as describe the treatment options available for hearing loss in older adults.
Hearing loss is the third most common chronic physical condition in the U.S. and is more prevalent than diabetes or cancer, according to the CDC. I think everyone listening here today can probably think of at least one person that they know that struggles with hearing loss. According to the NIH, approximately 15% of American adults report trouble hearing. Keep in mind that's only the people that report trouble hearing. I think a lot go unreported. Hearing aid users, on average, wait 10 years before seeking help for their trouble.
There's evidence to support that age-related hearing loss typically begins around age 30 and progresses with increasing age. Of those aged 20 to 69, age is a strong predictor of hearing loss, with the largest occurrence of hearing loss in those aged 60 to 69. 50% of individuals 75 and older are reported to have debilitating hearing loss, yet only 30% of this group has tried hearing aids. This is a huge gap that we are trying to fill. Because again, 50% of those age 75 and older have that debilitating hearing loss, yet only 30% of them have ever tried hearing aids or other assistive devices. In our office, I would say about 50% of the community that we serve are white adults aged 55 to approximately 90, with approximately 20% of our patient population between the ages of 18 and 55, and the remaining 30% are typically pediatric patients that we serve. So what causes hearing loss in adults? There are various different causes that may cause hearing loss to present, and this figure here does represent the majority of those causes. I'm going to talk mainly about a few of them that we tend to see most commonly in our office, and age, of course, is one of the most prevalent causes of hearing loss in older adults. Due to the anatomical layout of the cochlea, age-related hearing loss typically presents as a high-frequency loss, referred to as presbycusis. This tends to have the greatest impacts on someone's speech understanding, particularly in adverse situations and reverberant rooms. A lot of patient populations that you may serve may be people who are struggling with diabetes or hypertension. Both of these are also strongly correlated with age-related hearing loss. For diabetic patients, studies suggest a higher incidence of sensorineural hearing loss in those with diabetes than without. There's also a positive trend between the progression of diabetes and the severity of hearing loss. So as diabetes progresses further, the severity of hearing loss is also expected to decline. There's also a high correlation between hypertension and hearing loss. The belief is that hypertension causes that high blood pressure in the vascular system, which may lead to a hemorrhaging of the inner ear, resulting in a progressive hearing loss. Noise exposure is also a very common cause of hearing loss in adults and can be experienced in those who work in construction, dentistry, military, or the police force, musicians, and also concert attendees. People can experience permanent hearing loss from only one incident of excessive noise exposure, such as firearm shooting or explosions, without the use of hearing protection. But in addition to that, extended exposure over large durations of times, 8 hours of construction use per day for multiple days per week, does tend to create a decline in the hearing loss. Cerumen impaction is also another common cause of hearing loss and also typically reversible. With a complete occlusion of the ear canal from cerumen, patients can experience up to 30 to 35 decibels of hearing loss, which equates to a mild hearing loss in someone with typically normal hearing otherwise. Older and more active adults have a tendency to produce larger accumulations of wax, as well as those with smaller ear canals. So again, there are multiple different causes of hearing loss, and many of them are things that we see in our office, but the most common causes that we tend to see are related to diabetes, hypertension, noise exposure, cerumen accumulation, and age. So just moving on to the effects of hearing loss. This quote here was taken from the World Health Organization General Director, stating that our ability to hear is precious. Untreated hearing loss can have a devastating impact on people's ability to communicate, to study, and to earn a living. It can also impact people's mental health and their ability to sustain relationships. I think a lot of times we take our hearing and communication for granted, and it's not until that is lost that we really start to realize how much of an impact that can have on our lives, socially, educationally, and even professionally.
So I'm going to talk to you a little bit more about the effects of untreated hearing loss. For decades, age-related hearing loss was considered medically harmless. Over the last 10 years, however, researchers have been looking at how hearing loss impacts overall health. One of the major implications of untreated hearing loss is breakdown in communication. Hearing loss doesn't just affect the person with hearing that's struggling with the hearing loss, it also affects how they communicate with their partner, family, friends, and coworkers. Many people with hearing loss tend to just nod along and act like they understood something, even if they didn't. Just yesterday, I actually had a patient present for a cochlear implant evaluation. She's been wearing hearing aids and she was recently hospitalized. Unfortunately, due to COVID, she was alone in the hospital and she did not have her family with her. Throughout her visit, she nodded and agreed with her doctors, acting as if she understood what they were saying. It wasn't until after she was discharged that she found out that she had actually ended up agreeing to a heart surgery that she had known nothing about until the nurse had called to schedule. I think this really freaked the family out, realizing how much trouble she can get into with her untreated hearing loss, and so that prompted them to seek better treatment. And I think this is a good lesson for any of us medical providers to realize that I think we all tend to kind of nod along and act like we understand something, even if we don't. So just something to be aware of. Verify the understanding with your patient and make sure that what they seem to understand is true. On a societal level, because of their hearing loss, persons with hearing loss achieve significantly lower levels of education than do those with normal hearing. They also have higher levels of unemployment or underemployment and lower levels of income than those with normal hearing. Especially for younger adults with hearing loss, finding a job that relies on little communication can be very hard to find. If you have a patient that falls into this category, there is a government program called vocational rehab that's an excellent resource and can help individuals find employment as well as get access to properly fitted hearing aids. The results of some studies have suggested that hearing loss is independently associated with cognitive decline and dementia, possibly through the effect of hearing loss on cognitive load or through reduced social engagement. When listening becomes more effortful, more areas of the brain are being used for listening that may otherwise be used for memory or cognition. There are correlations between hearing aids and improved cognitive function, which we will explore more later on in this presentation. For people with hearing loss and their family and friends, conversations are really difficult. Every day we hear patients tell us how they are retreating from conversations, avoiding family gatherings, they've stopped going to church and other activities, all because their communication is too difficult and it's embarrassing to continue asking what. This kind of withdrawal can easily lead to social isolation, especially for older adults. Some studies suggest that women have a stronger association to hearing loss and social isolation, but I tend to see it in both genders.
So we'd like to dive a little deeper into hearing loss and cognitive decline. So this figure here was taken from a study by Livingston et al. In 2020. It's a follow-up study to their original study in 2017 that did identify 9 potential risk factors for dementia and cognitive decline that could have been prevented with appropriate treatment. So dementia is becoming a rising concern in the medical industry, with approximately 10 million new cases occurring per year worldwide and estimates of 152 million cases by 2050. Global costs are estimated to be approximately $1 trillion annually for treating dementia. So the study in here suggests that approximately 40% of dementia cases could be potentially modifiable with appropriate intervention. Hearing loss, of course, is not the only risk factor for dementia, and there are a lot of other overlapping risk factors, but hearing loss leads with an 8% risk factor in dementia cases, meaning that if appropriate referrals and treatment for hearing loss were to occur, we could potentially reduce the amount of dementia cases by up to 8%. One thing I really want to focus on with this study is that in these studies that they created, they did correct for hearing loss by placing hearing aids or other appropriate devices on individuals who did have hearing loss and were being treated or diagnosed with dementia. But a lot of times hearing loss and the symptoms of hearing loss overlap with symptoms of dementia, and people can be incorrectly diagnosed with cognitive decline simply because they are not hearing or understanding the assessments that are being administered to them. Individuals with progressive hearing and more severe hearing loss are at a greater risk for dementia when left untreated. There are specific actions stated in this article to treat hearing loss, to correct for that risk factor against cognitive decline, and that includes encouraging the use of hearing aids and reducing hearing loss by protecting the ears from excessive noise exposure. So even just convincing somebody to purchase hearing protection when they're in more aggressive noise environments can help to reduce that progression of hearing loss. And so if you remember earlier when we talked about those age 16 older having the highest incidence of hearing loss, and yet only the 30% of those 75 and older have ever tried hearing aids or other assistive devices. So this is a huge gap, again, that needs to be filled, and by making the appropriate referrals and getting someone treated for their hearing loss, we can not only improve their social isolation, their ability to communicate with others and form relationships, but we could also be reducing their chance at developing dementia and other cognitive decline. A little bit more from this study. This is another figure that talks about how treatments and appropriate referrals can be helping to prevent dementia. So the two different modifiable pathways include reducing neuropathological damage and increasing and maintaining cognitive reserve. By treating and managing hearing loss, ideally we are helping to increase and maintain cognitive reserve and therefore help to prevent dementia cases. And this leads us to discuss how treatment is administered for hearing loss. There are several studies referenced in this article that found that hearing aid use to be associated with lower incidence of dementia. In other words, those have hearing loss and do not wear hearing aids tend to have lower cognition, again, than those who do wear hearing aids. So this brings us into another study about hearing aid use.
So I'm going to talk to you about some research that's been going on out of the University of Colorado Boulder. And the researchers there have been studying how auditory deprivation, also known as hearing loss, treated via amplification, might literally change the brain's processing centers. This research began years ago by looking at children born deaf and how their brains changed in response to cochlear implantation. The findings were so robust that they wanted to see if the same was true for age-related hearing loss treated with hearing aids. In this study, the subjects were adults with mild to moderate age-related hearing loss who were matched with normal hearing controls. All of the hearing loss participants were fit with the same hearing aids. Soon after the hearing aid fitting, as well as 6 months post-fitting, the subjects were shown a visual stimulus, and cortical evoked potentials were collected to measure the brain activity. The researchers also tested speech perception and noise, as well as cognitive function in both groups. At baseline, the untreated hearing loss group exhibited visual activation plus additional activation of auditory regions in the brain when shown a visual-only stimulus. The hearing loss group also showed activation of the frontal cortex during this task. This activation of the frontal cortex may reflect increased effort or cognitive load. When compared to the normal hearing group, the untreated hearing loss group exhibited poor speech perception and noise, as well as significantly poorer cognitive function across all domains assessed. So as you can see in this slide, prior to the hearing aid use, when shown a visual stimulus, you can see that the visual areas of the brain as well as the auditory areas of the brain are firing. After the subjects had worn hearing aids consistently for 6 months, you can see that firing of the auditory center is no longer there, and they are just relying on the visual center. Not surprisingly, the researchers also saw significant improvements in speech perception and noise scores, as well as cognitive function in the hearing loss group at the 6-month follow-up. These results suggest that treatment with well-fitted hearing aids can provide a neurocognitive benefit. One thing I thought that was interesting about this study is that the subjects who were ultimately enrolled in the hearing loss group, a lot of them did not even know that they had hearing loss when they enrolled in the study. So I think that just points that, we're seeing these changes in the brain prior to people even realizing that they have a deficit.
So what can you look out for in your office that would suggest that somebody might have hearing loss? All of these facts about hearing loss may be fine to know, but what's most important is that clinically we are knowing how to identify the signs of hearing loss and we are making the appropriate referrals from there. So someone in your office who has undiagnosed hearing loss may respond inappropriately to responses to a question asked or a statement made. With hearing loss, again, that signal is distorted and people have a very difficult time understanding speech, and therefore they will try to fill in the gaps based on the context of what is being discussed. However, a lot of times they will respond inappropriately because they misunderstood what was being said. They will often lean in to achieve a better signal because the closer distance, the better the signal of the speech that's being presented. I cannot tell you how many times we see patients in our office that are simply there to placate a spouse or a family member. So a lot of patients will say, oh, no, I don't really feel like I have any hearing difficulties, but my wife told me that I don't listen to her. So this is also a very big sign that someone may have some untreated hearing loss. Tinnitus or tinnitus is also a side effect from hearing loss. It is not only found in patients with hearing loss, but it can present in multiple different forms. So a patient of yours may describe ringing, hissing, buzzing, cicadas, or other sounds that are not typically there in the environment. Tinnitus is a common symptom of hearing loss, and it results from the brain's response to a lack of input from the ears. So also if you're having patients reporting any type of ringing, hissing, or buzzing in their ears, that may be a sign that they have hearing loss. Hearing loss not only impacts how we hear other people, but it definitely impacts how we hear ourselves. And so patients with hearing loss may often lose the ability to monitor the level of their own voice and may talk louder in your office than is a typical average speaking level. And we talked a little bit earlier about social isolation and those effects from hearing loss. But it's a very, very common side effect from hearing loss because people become frustrated and unmotivated to continue to try and struggle in these situations. So if you ever have an individual in your office that's complaining that they're feeling isolated from others, it would also be a good idea to recommend them for referral. Of course, the best thing that you can always do is to ask your patients about hearing loss because looking for these signs, they're not always super obvious. So please ask your patients and talk to them about hearing loss.
So you may be asking yourself at this point, why are there so many people with hearing loss, but so little amount of people wearing hearing aids if they're so helpful? So I'm going to talk to you a little bit about some of the barriers to care. First of all, hearing loss is a hidden disability. It's not something that you can see like a broken leg or something like that. And especially with mild to moderate hearing loss when the signs aren't very obvious. Sometimes with people with mild to moderate hearing loss may just seem a little bit confused, like they're not understanding what's going on. And so in some cases, I think that family members or loved ones may not encourage them to seek the right help. They may encourage them to get a memory evaluation or something like that. That may also be a good idea, but the hearing loss could ultimately be missed. Further, there is not a lot of information available about the prevalence and the effects of hearing loss. The information available can also be misleading or incorrect. I think one of the most incorrect or misleading things out there about hearing loss is that there they're unaffordable. They're so expensive that nobody can afford hearing aids unless you have a lot of money. And this is not necessarily the case. Hearing aids are an investment, but I think people are often surprised at the reasonable cost that we can provide at our office. Moreover, it's more important to have a good audiologist than it is to have a good set of hearing aids, so please keep that in mind. There has always been negative stigma surrounding the appearance of hearing aids. I hope this is getting a little bit better, but I still think that people are afraid to wear them because they're afraid to look like they are elderly. People also associate hearing professionals with used car salesmen, which does realistically happen if you go to the wrong place. One thing that's not on here that I think is a really big barrier to care is a bad past experience. Many people say that hearing aids don't work for them or that they don't like them, and this kind of makes us wonder if maybe they were improperly fit or if there are some other confounding factors preventing the patient from accepting hearing aids. Things like social isolation, depression, anxiety. So, what can you do? As a primary caregiver, there are some things that you can do to help your patients access the proper hearing treatment. One thing that we've noticed lately is that hearing loss is becoming a much hotter topic in the news, and I think older adults are talking to each other more about it. I think people are wanting to do something about their hearing loss sooner than later, now that everybody's talking about how hearing and dementia are related. Oftentimes, people just don't know where to start the process of getting help, and I think that's where you can come in as the primary care provider. If you notice these behaviors in your patients, we hope that you remember the importance of properly treated hearing loss. We ask that you educate your patients about the impacts of hearing loss and point them towards an audiologist or a medical specialist if necessary. Every day we see older adults that have really tried seeking treatment through a hearing aid shop. Oftentimes the hearing aids they have purchased for thousands of dollars are inappropriate for their hearing loss. An inappropriately programmed hearing aid, unfortunately, is sometimes just as good as no hearing aid at all. We hope that you can help your patients avoid these costly mistakes. Some things that you can do in your office to help reduce the barriers of hearing loss include things like directly facing your patients and speaking slowly. Raising your voice does not necessarily help improve the understanding. However, slowing your rate of speech will help a lot. If appropriate, provide visual cues to your patients via lip reading. The most difficult sounds to hear are the easiest sounds to see on the lips. A personal amplification system is a piece of technology that is very easy to utilize in your office. It is a set of headphones that the patient wears and then a microphone for you to speak into to increase the volume of your voice. And finally, we ask that you ask about hearing loss. If you routinely work with patients 60 and older, consider making it part of your routine physical. We hope that you found our presentation informative, and we have a little bit of time to take any questions. There's no questions, so thank you, and we hope you enjoy the rest of the conference.
So our next speaker today is Dr. Timothy Haegen. Dr. Haegen is a rhinologist, meaning he's a specialist in taking care of patients with sinonasal disorders, chronic sinus disease, brain fluid leaks, sinonasal tumors. Dr. Haegen practices at our Arizona Sinus Center, division of Valley ENT located in downtown Phoenix. So with that, I'd like to welcome Dr. Haegen to the podium to give his presentation.
Good morning. Today I'm going to talk to you about myths of sinus surgery. I have nothing to disclose. The objectives of today's talk are to identify the types of surgical options available for patients with chronic inflammatory sinus disease. We're going to summarize the postoperative recovery and describe expected surgical outcomes. We'll first begin by defining chronic rhinosinusitis. Rhinosinusitis is defined as symptomatic inflammation of the sinus and nasal cavity. You have to have two of the following four symptoms: facial pressure, nasal obstruction, nasal discharge, and decreased smell. In order for it to quantify as chronic, it needs to be present for greater than 3 months. So this is a CAT scan with a patient with chronic sinusitis with polyps, greater than 3 months of duration. In terms of morbidity, chronic rhinosinusitis affects approximately 1 out of every 10 U.S. adults. It accounts for about 5 out of every 100 medical office visits, and approximately 500 or greater than 500 sinonasal surgeries are performed annually in the United States. Patients will admit that prior to undergoing sinus surgery, about 70% of them do their own research. The things that they're most interested in looking into includes risks and benefits of surgery and recovery-related issues. Younger patients tend to look to the internet for their information, and older patients more often rely on you, the primary healthcare provider. And that's why I decided to talk about this today. So there's 6 myths that we're going to undergo or talk about. And the first myth is that chronic sinusitis can only be treated with surgical options. Patients always have the option of proceeding with medical therapy as long as they don't have a pending complication or concern for a tumor. I have on my original slides a list of the medications that are commonly prescribed. There's 3 that are currently approved by the FDA, and that's topical nasal steroids, saline irrigations, and biologic modifier therapy. Before moving on to surgery, we often talk about maximizing medical therapy or adequate medical therapy. So patients need to fail this prior to considering the surgical option. And that is defined as greater than 3 to 4 weeks of systemic antibiotics, 1 to 2 weeks of systemic steroids, and topical nasal steroid sprays. The myth number 2 is that there's only one type of sinus surgery. Okay, and before we talk about the types of sinus surgery, let's kind of review the anatomy. The nose consists of the nasal septum and 3 turbinates on each side. The septum divides the nose into a right and left side. The turbinates are structures with tissue that humidifies air, warms air, and filters air. The sinuses are paired cavities that drain into the nose, and there's 4 on each side. That's the frontal, the ethmoid, the maxillary, and the sphenoid sinuses. So when we talk about sinus surgery, there's about 12 different procedures that we can perform. So when we look at the different surgeries, you have septoplasty, which is fixing the nasal septum, which is deviated in a large percentage of the population. We can reduce the turbinates, and then we have the sinus surgeries. And this consists of balloon dilation or traditional endoscopic sinus surgery. External approaches are rarely done and are mentioned only for historical purposes. Patients often come in and want to know if there's going to be incisions on their face, and the answer to that is no. So the goals of sinus surgery is first to ventilate the sinus. Second is to remove disease, which is usually polyp tissue, infection, or fungal debris. And the third goal is to provide access for topical medical therapy. So here we have a picture of a coronal CT scan of a patient with a bacterial infection that's demonstrated by the gray tissue on the left side of the patient. That is your right side. That black is represented by air. And we see a year later, after their sinus surgery, the sinus is well ventilated. A corollary to this is that all sinus surgery is invasive, and that's not true. There's multiple procedures that can be done with limited anesthesia and limited recovery in the clinic setting. The first is turbinate procedures, where we reduce the size of the turbinates. We can also do balloon sinuplasty, which is demonstrated here. The balloon is inserted into the maxillary sinus, and the sinus is then irrigated. We can also do limited sinus surgery and polyp removal. This is referred to as a microdebrider. This is an instrument that cuts and sucks tissue, much like a liposuction device. Patients will often refer to this as a roto-rooter. Finally, we can place drug-eluting stents. These release steroids into the sinus over a period of 1 to 3 months. Sometimes they dissolve, and sometimes they have to be removed. This is especially helpful in patients with polyps, and we see here one of those stents in the left frontal sinus. The third myth is that my eyes will be black and blue, and this is not true. This is a complication of surgery. There's minor and major complications associated with sinus surgery, and patients need to understand this. Major complications include cerebral spinal fluid leaks and other intracranial complications, orbital complications, and life-threatening hemorrhage. In a large study of about 80,000 patients, the risk of a major complication was about 0.33%. When we look at revision surgery rates, it doesn't increase that much more, and it's about 0.5%. But when you consider that there's greater than 500,000 surgeries performed annually in the United States, that means there's about 1,800 major complications per year. So this is not insignificant, even though it's rare. And patients are usually coming in and they're concerned about having revision surgery. But again, it's an important point that that doesn't necessarily mean they're going to more likely to have a complication. This was a study where patients were asked about their postoperative expectations prior to undergoing surgery. And what patients generally reported is that they underestimated the amount of bleeding after surgery. Even when it wasn't life-threatening, patients get a little bit of bleeding in the first few days. But what was most important about this study was that patients incorrectly believed, and that was about 50% of patients, that there was either no risk or only minor risk associated with sinus surgery. So preoperative counseling is very important when it comes to the complications. The fourth myth is that my nose will be packed and taking out the packing is painful. There's generally three concerns when it comes to nasal packing. Can I breathe? Does the packing hurt? And will it hurt when it's taken out? In my experience, patients overestimate all three of these. So let's look at packing a little bit. Packing can be absorbable or non-absorbable. It can be permanent. It can be in the nose or in the sinuses. This is nasal stents that's placed in the nose after a septoplasty. And they're rigid, but they have holes in there so people can breathe through them. Sinus packing is a little different. Sinus packing is soft. In this case, this is placed in the right ethmoid cavity, and this is a dissolvable packing. So this is a patient with permanent packing or non-absorbable that has to be removed. But again, it's soft. In both cases, the patient can easily breathe through their nose. And this is that final type of packing, which are the absorbable stents, or in this case, a non-absorbable drug-eluting stent. This releases steroid over time and decreases patients' exposure to systemic steroids. This was a nice study looking at the morbidity of packing. Specifically, they looked at pain and blockage with packing. And they were graded on a scale of 0 to 10. And in terms of pain, patients averaged a 2 to a 4. In terms of blockage, patients averaged a 3 to a 4. Patients that had absorbable packing tended to do slightly better than patients with non-absorbable packing. The fifth myth is it'll take a long time to recover. In general, patients require about 1 to 2 weeks to recover from surgery. We modify their activity for up to 3 weeks, but what they care most about is pain associated with the surgery. And we can correlate pain with the total narcotic use. In this study, the average patient consumed about 8 pills after surgery, usually within the first 3 or 4 days. Most patients are not taking pain medications by day number 3. And in this specific study, there was no association with stent or placement of packing and higher narcotic use. These are the two graphs from the study. On the left, we see narcotic use over time, and on the right, we see total pain scores over time. And what's important is that they correlate. Pain is greatest on postoperative day number 1, and it quickly tails off by day number 3 or 4. This was an interesting study about looking at 179 different surgeries. And what they did is they rated the postoperative pain on day number 1. And what we see is that paranasal sinus surgery was near the bottom at 148. Septoplasty was around 122. And neither of these was close to what a tonsillectomy causes. But tonsillectomy patients can rest assured that they're not having an open reduction of a calcaneal fracture, which took home the award as the most painful procedure in this study. Not all patients recover to the same extent or have the same amount of pain. Risk factors for more pain in the postoperative period include more complex sinus surgery. Undergoing septoplasty with sinus surgery is more painful than either procedure alone. Active smokers and patients with a primary headache disorder like migraines tend to have a harder recovery. And in multiple studies, packing has mixed results. What's most important is that patients undergoing revision sinus surgery do not have a greater level of postoperative pain. In fact, in my experience, patients that are undergoing revision surgery have less pain. So for those patients who probably had a bad experience with sinus surgery, it's important that you encourage them to get an opinion if they feel like it didn't work. In terms of outcomes, there's 4 things we look at to measure whether sinus surgery works. First is, do we meet patient expectations? Second, we can look at patient-reported outcome measures. Third, we can look at objective data like endoscopic scores or CT scores. And finally, we can look at revision surgery rates. So in terms of meeting postoperative expectations, this was a study from 2019 in which Smith reported that only 60% of patients found that their postoperative improvement in symptoms matched their preoperative expectations. However, 88% would recommend surgery to a family or friend, and patient-reported outcome measures were high at greater than 75% improvement. So this is a relatively low number in terms of meeting patient expectations, but what's most important about this is that patients have realistic expectations going into surgery. In that same study we looked at before, where patients were asked about their expectations, about 30% incorrectly believed that they would never have a sinus infection again. So it's important in the preoperative counseling session to let patients know that we're modifying the disease, we're improving symptoms, but we're not curing the disease. This is the most common patient-reported outcome measure, and it's ironically called the SNOT-22. This is not referring to snot in the nose, but it stands for the Sinonasal Outcome Test. This is 22 symptoms that are associated with sinusitis. Each one is scored from 0 to 5, so you can get a score of anywhere from 0 to 110. Lower scores suggest better overall quality of life, and if you don't have sinus disease, you probably score somewhere around a 10 or 9. This is included in your packets, and I would encourage you all to take this test. And if you don't have a primary headache disorder and you score greater than 30, I would get a CAT scan. Studies show that the overall improvement in SNOT score is about 24, and that correlates with about a 50% reduction in total score. The greater the preoperative score, the more likely you are to demonstrate benefit. Patients often don't care about a total score. What they care about is individual symptoms. And what we have is we can break these down into 5 domains. On the left, we have sinus-specific domains, and on the right, we have general quality of life measures. So on the left, we break this down into rhinologic symptoms, which include runny nose, sneezing, nasal obstruction, thick nasal drainage, extra-rhinologic, which is postnasal drainage and cough, and ear and facial symptoms, ear consisting of dizziness, fullness, and facial pressure. On the right, we see psychological and sleep dysfunction. This is important because patients can then kind of get education on whether what symptoms they care most about and most likely to improve. What we find is whether patients choose medical therapy or surgical therapy, they significantly improve across all 5 domains, but the sinus-specific domains improve at a greater rate than the general quality of life improve. Why is this important to you? Well, about a quarter of your patients with chronic sinusitis have a comorbid diagnosis of depression or anxiety disorder. And what we find is that after sinus surgery, the total score for the psychological domain decreases by about 40% in patients with depression. So we have evidence-based medicine showing improvement across multiple areas. We just talked about the quality of life improvement. Smell improves in the majority of patients. Asthma control improves, and by that, patients have less symptoms. They use less medications. And interestingly, patients that do not have asthma are less likely to develop late-onset asthma if they undergo sinus surgery. We also see less systemic medications used for chronic inflammatory sinus disease, and that means less systemic steroids and less antibiotics. In terms of work, patients are more productive, and they're absent from work less often. In terms of long-term studies, the revision rate is about 15 to 20%. Long-term means when we measure outcomes at 5 to 10 years. A corollary to this is that if I have polyps, my polyps will just come back and I'll need surgery again. That's not true. The revision rate for patients with polyps is about 19%. However, there's certain types of polyp conditions that have a higher or greater recurrence rate and therefore need surgery more often. This includes allergic fungal sinusitis, and aspirin-exacerbated respiratory disease. So it's important that we take time to figure out what type of polyps these patients have. We use pathology, history results, and CT scans, and then we can counsel them preoperatively accordingly. Also, patients with asthma and polyps have a 3 times greater risk of needing revision surgery than patients with polyps alone. So this is a list of the failures of surgery. The first was scar tissue, which is seen in this picture. This is a patient's right nasal cavity. The septum is on the right, the middle turbinate is in the middle, and the sinuses should be to the left, but there's scar tissue blocking it, much like my slides. So I just talked about patient disease in terms of the different types of polyps that affects the outcome. Comorbid diseases like autoimmunity, certain types of autoimmune conditions and cystic fibrosis also lead to higher revision rates. Surgical technique in terms of what's being done and how it's done, and then what's important to you all is patient compliance. It's important that you guys understand what's being asked of patients and then encourage their compliance. After surgery, we use high-volume saline irrigations. We also place medicine in these saline irrigations over the long term to help modify the disease and improve outcomes. The media doesn't help in terms of our myths. And in fact, here's an article from 2002 in the New York Times, which questioned the results of sinus surgeries. And what it states is that many physicians thought that the new tools would help cure the disease, but now as many of those patients who are returning to their doctor's office after the procedure, once again, the early hopes for surgery have been dashed. Well, this is problematic in 2 ways. First, we're not curing the disease, we're modifying it, much like you modify asthma. And second, you have to put this in the context of the time period when this was written. Sinus surgery became popular in the late 80s, so for the next decade, physicians were basically learning on the job about sinus surgery. And what we see is in the last 2 decades, results have significantly improved. In one study, looking at surgery prior and after 2008, the revision rate 2008, the revision rate was 23%. After 2008, the revision rate for surgery was 17%. So why is this? Well, there's basically 3 reasons. Endoscopic techniques have evolved, instrumentation has become more advanced, and adjuvant medical therapy has become more effective. The last reason is probably the most important. Steroid rinses were introduced around 2007 and have dramatically improved surgical outcomes. We talked about drug-eluting stents. Both of these decrease patients' exposures to systemic steroids. Most exciting is probably biologics. These are newer medications, and there's currently 3 that are approved for chronic rhinosinusitis with nasal polyps. These are demonstrating some dramatic results in our patients. Currently, it's only for patients with polyps and not patients without polyps. But this is changing rapidly, and I anticipate in the next few years we'll have a lot more of these available. This is probably a good place to stop. So in summary, patients have preconceived opinions of sinus surgery that are often false. Multiple surgical options are available to patients, and what a friend or family member has had done doesn't necessarily correlate with what they're having done. Complications are rare, but possible with endoscopic sinus surgery, and good preoperative counseling is important. And finally, innovations in nasal packing, surgical technique, and instrumentation have been introduced over the last 3 decades, leading to easier recovery and improved surgical outcomes. Thank you.
So our next speaker this morning is Dr. Jordan Weiner. Dr. Weiner is a founding member of Valley ENT and served as past president. Dr. Weiner practices comprehensive otolaryngology, but has a particular interest in the treatment of obstructive sleep apnea. And so he will talk to us this morning about obstructive sleep apnea and some of the newer techniques and technology we have at our disposal to treat this serious medical condition. So with that, I'd like to introduce Dr. Weiner to the podium.
Ready? Good morning. Thank you, Dr. Cassis, for the introduction. And we're going to talk about obstructive sleep apnea, which to me is near and dear to my heart. Acknowledgements. I am a consultant with Inspire Medical Systems, which is one of the technologies that I'll be speaking about this morning, and I serve on their physician advisory panel. I have no other conflicts to disclose. Our objectives today are to identify the prevalence, pathophysiology, and risk factors for obstructive sleep apnea, to discuss the sequelae of untreated obstructive sleep apnea, and to review the various treatment options available today for the treatment of obstructive sleep apnea. There have been many studies published looking at prevalence of obstructive sleep apnea. One of the landmark studies that was performed at the University of Wisconsin, where they essentially sampled a very large segment of the Wisconsin population at large who did not carry a diagnosis of sleep apnea. They had over 1,500 patients selected between the ages of 30 and 70. And then they did sleep studies on all of these people and found that the overall prevalence of sleep apnea in this population was 26%. But if we eliminate mild sleep apnea, which carries less health risk, still the incidence, or I should say the prevalence of moderate to severe obstructive sleep apnea, which is an apnea-hypopnea index greater than 15, was 10%. Furthermore, you can see a twice as high incidence of sleep apnea in men compared to women, with 13% of men having moderate to severe obstructive sleep apnea. Of this enormous segment of the population that has obstructive sleep apnea, the estimate is that about 75% is undiagnosed, and that includes severe sleep apnea. So very high burden of disease in the population, and most people don't get diagnosed. So what happens during sleep apnea? Well, it is a function of how the throat works, in that we use our throat for both swallowing and breathing. And from an engineering perspective, that's kind of odd. We put everything in one hole, whether you're swallowing it or breathing in. And the problem is that when you swallow, the entire walls of the throat must collapse and squeeze to push the food into the esophagus. But when you breathe, it needs to be open. But this means that this tube that you're breathing through is collapsible. And during sleep apnea, the walls of the throat do collapse, obstructing the airway. It can collapse in the anterior-posterior dimension. It can also collapse from side to side in the lateral dimension. And many patients, about 50%, will have multiple levels of collapse in different parts of the throat. This doesn't occur during the day because of a couple of factors. One, you're usually upright, and two, muscle tone is much greater during the day, and so active muscle tone prevents the muscular walls from collapsing. The main dilator of the airway is the genioglossus muscle, which moves the tongue anteriorly, and it's been shown to have increased activity level during the daytime in patients with obstructive sleep apnea as a means of compensating for their poor airway. But this increased muscle tone of the genioglossus disappears once they fall asleep. Screening patients for sleep apnea is an important objective in primary care, because, as you just saw from the previous slide, about 10% of your patients have moderate to severe obstructive sleep apnea, and most of them aren't diagnosed. One of the popular screening tools is called the Stop Bang questionnaire, and that's an acronym that includes asking if the patient snores loudly, are they tired or sleepy, are there observed apnea or choking episodes by sleeping partners, do they have elevated blood pressure, is their body mass index over 35, age greater than 50, a neck circumference over 16 centimeters, and male gender. These are all known risk factors for obstructive sleep apnea. Symptoms of obstructive sleep apnea are loud snoring, which is present in most but not all patients with obstructive sleep apnea, choking episodes at night, which may or may not wake the patient up but would be observed by a sleeping partner, insomnia, paradoxically. many patients with obstructive sleep apnea actually have difficulty falling asleep or staying asleep. Having to get up to go to the bathroom at night, witnessed apnea, of course, difficulty with memory loss and cognitive impairment, depression and irritability, and decreased libido. This slide I would consider the most important slide for people to think about in this entire lecture, because this is, again, going back to that Wisconsin study where they looked at both overall mortality as well as risk of death from cardiovascular causes. And what you see plotted here is time. They followed patients up to 20 years in this study, and you see different cohorts. Each line here represents a different group. The top very light gray line shows people essentially who don't have sleep apnea with an AHI less than 5. You can see over the course of the 20 years, about 5% of them died for various reasons. Each line below that then represents mild, moderate, and severe obstructive sleep apnea with all-cause mortality. And what's striking is the patients with severe obstructive sleep apnea, approximately 40% of them died during the study, compared to about 5% of patients who did not have severe or did not have any sleep apnea. And so not diagnosing obstructive sleep apnea is very dangerous for the patient because it is likely to significantly affect both the quality as well as the longevity of their life. And just to give you one particular statistic, if we look at death from cardiovascular causes, the relative risk of dying from cardiovascular cause if you have severe untreated obstructive sleep apnea is 5 times higher than the general population. That's a 500% increased risk. Another important point on this slide is that the presence of sleepiness, so excessive daytime sleepiness or fatigue, did not correlate with outcomes. So for the patient who says, I don't have a sleeping problem, I feel fine during the day, we cannot then say, well, therefore your sleep apnea isn't going to exert a toll on your health. It's going to anyway, even if they're not sleepy. Oops. There are a lot of ways that obstructive sleep apnea contributes to heart disease. One of the biggest causes, it is thought, is the activation of the sympathetic nervous system. This has been documented in patients with obstructive sleep apnea. Specifically, with every apneic episode, there is a surge in catecholamine levels within the circulation. And this does everything you would expect catecholamines to do. It increases heart rate, cardiac output, peripheral vascular resistance, and also increases renal tubular sodium resorption. All of these will contribute to hypertension and not just nocturnal. And there was a Mayo Clinic paper published that showed that untreated obstructive sleep apnea was as significant a risk factor for ischemic heart disease as obesity, smoking, and hypertension. Arrhythmias are extremely common in patients with obstructive sleep apnea, including bradyarrhythmias, but most of the time tachyarrhythmias such as atrial fibrillation. Obstructive sleep apnea is one of the leading causes of AFib, if not the leading cause. Pulmonary hypertension, as well as diastolic dysfunction, are seen in patients with untreated sleep apnea. There is an increased effective afterload of the left ventricle due to the decreased intrathoracic pressure during apneic events. There is also increased platelet activation and aggregation with reduced fibrinolytic activity, leading to increased risk of thrombosis. And there's increased oxidative stress with accelerated coronary artery disease. Therapy. Prior to CPAP, the only real therapy for obstructive sleep apnea was a tracheostomy. But in 1983, Sullivan introduced the concept of applying positive airway pressure to the patient during sleep, and that launched CPAP. This basically uses pressure, air pressure within the throat to stent the walls apart so that they don't collapse during sleep. And that prevents the sleep apnea. There are a number of variations of PAP therapy now. We have auto PAP, where the PAP machine itself will vary the pressure to effectively eliminate their sleep apnea. There are multi-level or bi-level PAP units that give them a higher pressure during inhalation versus exhalation. And there's even something called adaptive servoventilation for patients who have central sleep apnea, which we won't go into. For patients who have very mild sleep apnea or who are intolerant of CPAP, there are alternatives. And the other non-surgical alternative for obstructive sleep apnea is use of an oral appliance. The most common oral appliance for sleep apnea is something called a mandibular advancement device, and there are about 100 of these on the market in the United States, and they are most effective for mild sleep apnea. If there is a patient who is intolerant of CPAP, you can use it for moderate to severe sleep apnea, but the probability that it will provide successful management of their sleep apnea is much less. Studies show mean reductions in AHI of anywhere from 30 to 70%, and an overall success rate anywhere from 45 to 100%, depending on which patient population you're treating. Compliance for oral appliances tends to be higher than CPAP, and can be as high as 80%. There are surgeries for obstructive sleep apnea, and to perform surgery for sleep apnea, we really need to identify and target the specific cause of obstruction. Otherwise, the surgery is not likely to be successful. There is no one single surgery for obstructive sleep apnea. Tonsillar enlargement, whether it's the adenoid, the palatine tonsils, or the lingual tonsils, can certainly cause sleep apnea, and if the patient has tonsillar hypertrophy, this is an excellent surgical treatment for sleep apnea. Palatal and lateral pharyngeal collapse can be treated with a procedure called a uvulopalatopharyngoplasty to essentially stabilize the lateral pharyngeal walls. And there is also a procedure called expansion pharyngoplasty, which further widens the posterior pharynx. We'll talk a little bit about uvulopalatopharyngoplasty. This surgery was essentially described in the 1980s. And became quite popular in the 90s until we realized that this is not effective for many patients because we weren't really selective in targeting the right patient group with this. It is still performed today, though, for the right patient. This consists of resection of a small amount of the distal soft palate and uvula, but in most surgeons' hands who are doing this procedure, there are a number of modifications that allow the lateral pharynx to be widened and stabilized for much better results. The results of this procedure are consistently better when a concurrent tonsillectomy is performed. So if a patient has already had a tonsillectomy performed, uvulopalatopharyngoplasty is usually not going to be a great option. The best patients for this surgery are patients who have larger tonsils, who are thinner, have a smaller tongue, in a lower position in the mouth. One of the most recent developments for the treatment of obstructive sleep apnea with surgery is something called hypoglossal nerve stimulation. People use the term Inspire to describe this procedure, but Inspire is the device that is currently FDA approved for hypoglossal nerve stimulation in the United States, but hypoglossal nerve stimulation is really what the therapy is. And this involves placement of an electrode on the hypoglossal nerve and a pressure sensor in the chest wall musculature. And the system, when it detects inspiration, delivers an impulse to the hypoglossal nerve, causing the tongue to move forward. So we're activating that genioglossus muscle, which opens the airway posteriorly. This forward movement of the tongue also pulls the soft palate and the epiglottis forward through coupling, and that opens the entire upper airway from the palate to the epiglottis. The impulse, as I said, is synchronized with breathing because of the placement of the pressure sensor between two ribs in the intercostal space. And that way, the stimulus is only delivered during inhalation when the tongue moves forward, and during exhalation, the tongue relaxes. Can anybody play those videos? I don't have a laptop here. If we click on the first one. In this video, you can see a patient with obstructive sleep apnea at the level of the tongue base and epiglottis. You can see the tongue base and epiglottis completely obstructing the airway. The second panel, just stay up here, shows at a higher level in the throat behind the soft palate. You can see the soft palate is touching the posterior pharyngeal wall, which is at the top of the screen, and the soft palate is at the bottom of the screen. So that's looking at the airway from above in the nasopharynx. On the right side, we're showing with Inspire stimulation at the tongue base. There's stimulation. You can see the epiglottis and tongue move forward, and then it's off during exhalation. And then in the last panel, you can see at the level of the soft palate during stimulation, the soft palate is moving forward. Okay, thank you. It's not advancing now. Sorry about this. Okay. There have been a large number of papers already published in the last 10 years looking at the effectiveness of hypoglossal nerve stimulation therapy for obstructive sleep apnea. And the ADHERE registry, which I participate in, is a multinational, multi-institutional cohort of patients who have received the Inspire device for their obstructive sleep apnea. And results of the ADHERE registry have been published over the years. There's currently far more than the 300 patients that you see on the slide. It's in the thousands now. There's a couple thousand patients in the registry. But we see from the results of this registry that the mean apnea-hypopnea index decreased from 36 to 10, and the absolute AHI reduction was about 25, which is a 71% decrease. Success, which is defined as a reduction of AHI of greater than 50% and a final AHI below 20, is achieved in about 80%. Some patients will actually achieve, about 50% will achieve an AHI in the normal range, which is less than 5. Average use of Inspire per night is 6.5 hours, which is substantially greater than CPAP. And 90% of patients reported a better experience with Inspire than CPAP, and the overwhelming majority would do it again. Complications are quite rare and usually transient. It's not advancing again. That video messed it up. Criteria for receiving hypoglossal nerve stimulation therapy is moderate to severe sleep apnea, so an AHI between 15 and 65, a BMI less than 35, adults greater than 18 unless the patient has Down syndrome, intolerance or non-compliance with CPAP. They must have a recent sleep study within the past couple of years. Central sleep apnea cannot represent more than 25% of their total AHI, and they cannot have something we call complete concentric collapse of the airway at the level of the soft palate on sleep endoscopy. Future developments are evolving rapidly with this type of therapy. And I think that over the next 5 to 10 years, we're going to see tremendous advances in the management of obstructive sleep apnea. One advance is going to be our improved ability to phenotype, meaning place patients into different groups based on physiologic or anatomical criteria to really optimize selection for these procedures. In addition to Inspire, there are other systems that are currently in development. I've mentioned a couple right here that will be things that we'll be considering over the next couple of years. And there may be other nerves that we begin to stimulate, like the ansa cervicalis nerve, to actually stimulate the strap muscles and stabilize the lateral pharyngeal walls. That's it. Thank you. We just received a question that I'll go ahead and answer. The question is, does this therapy result in any discomfort? The answer is generally no. The hypoglossal nerve is a motor nerve, so it does not have any sensory fibers, so there's really no direct perception of pain with therapy. Overstimulation of the nerve can be uncomfortable, and we don't want to do that, but as long as the stimulus level is set in a comfortable level for the patient, it is not uncomfortable. Occasionally, someone will find some soreness on the side of their tongue if their tongue is rubbing against their teeth as it moves back and forth. This is not a common problem and usually goes away over time, but the therapy itself is not painful or uncomfortable.
So this is to answer a question that was asked from our first presentation today on healthy aging and hearing loss. The question was, when are hearing aids recommended or indicated in patients with hearing loss? So there's two answers. A short answer is almost everybody with hearing loss, they are candidates for some sort of hearing device, whether it be a hearing aid or any other type of therapy or any type of other technology such as implantable hearing devices, cochlear implants, and so on. The longer answer to that is it depends. So if you take two patients, let's say both with a mild hearing loss, patient A with a mild hearing loss may not notice difficulties with their hearing on a day-to-day basis because of the compensation mechanisms, lip reading, turning their heads, avoiding places that are more challenging like noisy environments. That patient may not want hearing aids. Ultimately, it's going to be up to the patient how they treat their hearing loss. Patient B with a mild hearing loss may have more hearing demands, meaning they're struggling in meetings, having difficulty hearing their close friends and family members, struggling in other situations, social situations. So that patient, we would more strongly recommend hearing aids. However, as the presenters mentioned earlier, there is a risk of hearing loss with cognitive decline, and that risk is cumulative. So if a patient presents with hearing loss more in the middle ages, we may be more aggressive treating that even mild hearing loss, because over time, as hearing loss may progress, that's more and more risk of cognitive decline and ultimately dementia. The risk is about two times the risk of dementia with a mild hearing loss, up to about 5 times the risk with a more severe hearing loss associated with cognitive decline. So ultimately, it's up to the patient. The patient makes the decision about how they treat their hearing loss. But most folks, especially over a mild hearing loss, we do recommend hearing aids if they are a hearing aid candidate, or any other type of device that they may qualify for if they're not a hearing aid candidate. Thank you. So with that, I'm going to introduce our next speaker for today. Our next speaker is Dr. Timothy Kelsch. Dr. Kelsch practices at our Osborne Clinic in the heart of Old Town Scottsdale. Dr. Kelsch is an Arizona native, trained in the Naval Medical Center in Washington, and then returned to practice with Valiant. He's been with the group for over 12 years now. He practices comprehensive otolaryngology, but has a particular interest in head and neck surgery, treatment of thyroid disorders, skin disease, and skin cancer. So with that, Dr. Kelsch will talk to us about cutaneous cancers of the head and neck and the treatment of those conditions. So with that, I'd like to give a warm welcome to Dr. Kelsch.
Okay, well, hello, and I'm Dr. Timothy Kelsch. Thank you. I was not naval, it was Army, but I appreciate the plug there. So I practice here in Scottsdale in sunny Arizona, and I'm going to talk today about cutaneous cancers of the head and neck, something that really affects quite a few providers here in Arizona, because we see an aging population in a very sunny environment, and so this is something that we have to deal with very regularly. So I have no financial disclosures. So today, really, we're going to discuss the differential diagnosis for skin cancers, and as well, the treatment for one of the more feared ones, malignant melanoma. And then lastly, go through the general principles of surgery for skin cancers, as well as adjuvant therapies, which include radiation and systemic therapy. So skin cancer is the most common cancer in the world. It affects 3.5 million Americans every year or more. It might be 4.4 this last year. And 100,000 of those will end up being melanoma, which is the very feared skin cancer, due to its risk of potential spread and metastasis. 1 in 5 Americans will develop skin cancer over age 70, and that's to the tune of about $8 billion or more in skin cancer therapy. There are many risk factors. Generally, light skin and sun exposure as well as age are the big risk factors, but UVA and UVB rays, light skin, blue-green eyes, blonde-red hair, a large number of moles, really multiple sunburns at a young age. Under age 16 increase that risk. Indoor tanning, which we'll talk about in a second, and I want to make a special note to immunosuppression. We're in an age and era with biologic therapies that have really changed the treatment for a lot of autoimmune diseases, and this has also accompanied organ transplant, and so immunosuppressants are very prevalent, and this raises the risk of skin cancers, creating a whole new category of patients that we need to watch very closely. So indoor tanning, I just think it's worth mentioning. A lot of people like to prep for that summer suntan, and UV devices have been followed for years for sun tanning and have shown to be a high carcinogen. They're a group 1 carcinogen by the World Health Organization, and in some countries they're actually banned under age 18. The Swedish did a study showing a direct correlation with indoor tanning and skin cancer development. And currently there are about 420,000 cases per year directly linked to sun tanning in the tanning booths, and 10,000 melanomas. So the differential diagnosis includes basal cell and squamous cell carcinoma. That's about 95% of all skin cancers. The remaining 5% include melanoma, which is a big component, and then a much smaller component of the sarcomas and Merkel cell carcinoma and sebaceous carcinoma. So basal cell is around 2 million cases per year in the United States. It's usually a raised lesion with what we describe as pearly telangiectasias and rolled borders. Sometimes it can be kind of a scaly, reddish, shiny scar. It's typically treated with surgery and very effectively. There are other adjuvant therapies like radiation that's really reserved for patients who are very poor surgical candidates or have an area that is highly sensitive, like the medial canthus of the eye. So we said this is a surgical disease. The 5 different types include superficial, morpheoform, nodular, infiltrative, and fibroepithelioma. The most common is the superficial, and this occurs about 80% of its prevalence in the head and neck. Typically, you'll hear about these cancers in the head and neck, and they'll be very focused on an area around the eyes, nose, and mouth that we call the H zone, kind of right across the eyes, down the middle, and across the mouth. It includes the ears, and those are very sensitive areas because they don't have a lot of skin to give when you're removing them, and so you have to be a little cognizant to function and form. And so in the 1930s, Frederick Mohs came up with a technique called Mohs micrographic surgery, where the skin is resected in a kind of a beveled fashion and evaluated with horizontal pathologic slices that allow for a little bit better correlation of resection with the skin cancer's presence. And with that, they've had around 98 to 99% cure rate with Mohs in kind of typical cases, and up to 94% in recurrent cases. So you'll commonly hear Mohs micrographic surgery when you're talking about resection of basal cell in those sensitive areas. Basal cell does not typically go to the lymph nodes, and there are alternative therapies like radiation. There's also systemic therapy for people who do develop a more severe form of basal cell where it's more recurrent and extensive. And it uses an immunologic checkpoint called the sonic hedgehog pathway. My kids would love that. And there's a drug out, Vestibular, it's very hard to say, that will help in some of those patients. So this is a kind of a typical patient who's been out in the sun for most of his life and develops a lesion on his nose, goes to see his doctor who says we should get a biopsy of that and sends it to the dermatologist. Dermatologist says, wow, this is a basal cell carcinoma and we need to take this off with surgery. I recommend a Mohs micrographic surgeon so that a small defect can be made and we can have a little bit more room for reconstruction. There's several ways to reconstruct, including a skin graft, moving tissue around called adjacent tissue arrangement, or even moving tissue into an area called flap rotation. So in this one, we use a bilobed flap where we had a defect that showed a good portion of the tip of his nose is now exposed. But this gentleman wanted a one-stage procedure, one and done, and have the sutures removed and be done with this. So we used this bilobed flap where a segment that's about the size of the defect but a little bit smaller is moved into the defect, and then a smaller segment is moved into that empty space, which we can see next, and then closed. And after sutures removed and a little bit of time of healing, I think this was about a 3-week or 4, maybe a little bit longer, maybe a 6-week follow-up on the last picture, you see a pretty good result. The second most common cancer is squamous cell carcinoma of the skin, and it encompasses about 750,000 cases in the United States per year. It's usually like a scaly patch that begins to bleed or a sore that won't heal. It usually is a progression from actinic keratosis, which I'll have a picture of in the next slide. And in invasive squamous cell carcinoma of the skin, you'll see keratinocytes invading with keratin pearls and nuclear pleomorphism. So here's a gentleman on the upper slide that may have started with a kind of a scaly plaque on the lower slide until it became kind of ulcerated and scabby, and then began to have these edges that showed that there's clearly something wrong. 97% of these are progressions of actinic keratosis and a P53 mutation. In general, the radiation from the sun injures the DNA and causes a cross-coupling of DNA strands, and then injures tumor suppressor genes, and eventually the cells are allowed to start growing out of control. This particular one, squamous cell like basal cell, is most often treated with surgery. And again, you can think of Mohs micrographic surgery in that special H zone, across the eyes, down the nose, around the mouth, including the ears. And like basal cell, for primary tumors, radiation is an option for very sensitive areas, like the medial canthus of the eye, or in somebody who can't have surgery. Unlike basal cell, you have to worry about lymph nodes in squamous cell carcinoma. And in fact, we talk a lot about melanoma because we have about 100,000 cases per year here in the United States and around 7,000 deaths. And with squamous cell, we have almost the same amount of deaths every year. And it's really not given the same kind of fear and attention all the time. So you want to do a very good clinical examination on your patient and make sure that there isn't any lymph nodes involved, there isn't any involvement. Sometimes nerves will get involved, and you'll feel like a band of scar tissue that is actually tumor growing underneath the skin along a nerve. And so we want to evaluate their lymph nodes, which may include imaging, and then it may include what's called the sentinel lymph node biopsy, which is evaluating the lymph node that is the first bus stop out of that region for our lymphatic drainage system. Sentinel lymph node biopsy for squamous cell carcinoma is really indicated if these features on the right you have more than 2 of those. So a fairly big size with a fairly deep invasion, nerve or vascular invasion, and aggressive features. And then I come back to those immunocompromised patients. They're kind of a setup that their immune system isn't checking what's happening all the time. So here we have a gentleman who had kind of an interesting story, which I've heard before, which is he had an injury. In his case, he fell, scraped his nose, and while the rest of his face healed just fine, his nose started growing an extra bit of tissue. And so here you can see this exophytic hypertrophic tissue extending from his right side of his nose. And you might look at this and say, well, wow, why did he wait so long? But it grew really fast. It was about 2 to 3 months, and he was already, within a month and a half, he was already seeking care, going, this thing is not healing and it's getting a lot worse. The biopsy showed squamous cell carcinoma, and a Mohs micrographic surgeon resected this, which included a full thickness defect of his nose. This is a big problem because the inside lining is gone, the cartilaginous framework is gone, and the outside lining is gone. So we first divide the nose and any area of a defect into the subunits that seem to be affected. Specifically the nose, we were looking at the alar subunit here and half of the tip subunit. And we marked out what we will need to do to reconstruct and have it look appropriate. Then I took lining from the inside of the nose, called the mucoperichondrial flap from the septum, and I flipped that out to line the inside of the nose, took cartilage from his left ear, which is seen on the top left, as a reconstruction of the ala, and then I used skin from his forehead, still attached to a blood supply, to cover the nose, And now it has a blood supply for all that stuff that is being put in there to heal. And here we see him with, and you have to really counsel them well, that this is going to be a very odd 3 weeks of their life. And we counseled him that there's going to be this pedicle with all this soft tissue attached. And I was very generous because I did not want that soft tissue to not have a blood supply. So I left a little bit thicker pedicle than I normally would. And left it for 3 weeks and then separated those pedicles, reinserted everything where it's supposed to go, and he ended up with the result he has there. Now, he was so happy, because usually there's another stage and a step to reconstructing this, and he said, "Doc, I want to ride my horses," and he did not come back for that second stage, but did keep in touch with me, telling me everything was healing very well, and he was super happy. He could breathe. He felt like he looked like he did before, as close as to be expected, and he was back to his activities. So this is a gentleman with a scalp carcinoma who started as an actinic keratosis and fairly quickly began bleeding, and he would scratch at it, and it's not exactly in a place in your body that you can stare at. And it began to grow, and eventually he was seen by a dermatologist and recommended to a Mohs micrographic surgeon. We discussed a sentinel lymph node biopsy on him, and he elected not to do it. And we also discussed a reconstruction without skin grafting. So in this slide, he had the tumor resected, and we used a bipedicle flap to close and reconstruct that area. And you can see it takes quite a bit of movement to get tissue to close in the top of the scalp. Here's a gentleman whose ear had a lot of sun exposure, and he grew this lesion that wasn't healing. It was kind of scabbing and ulcerating. And so, we did a biopsy and knew it was squamous cell carcinoma, and we talked about Mohs, but he kind of wanted a one-and-done approach. And so I took him to the operating room, resected the tumor, which had very visible borders here, and then sent it to the pathologist while he's still asleep and cleared the margins, and then attempted our reconstruction. And so my plan was to remove a little bit of the purple area so that we could get the helix, which is the outside areas of the ear, to retouch in the middle. And so you can see that we resected a bit of that tissue and then advanced those flaps back together, and he had a very normal-looking ear, but a much smaller ear. It's about 2/3 the size of the other ear, but because the ear isn't usually stared at, both ears at the same time, most people never notice, and he was very happy. And after the suture removal, back to his dermatologist. Lip is a very unique area that I think needs mentioning, because the lip has two types of skin, keratinizing and non-keratinizing skin at a junction called the vermilion border. The lip of the upper lip will typically have basal cell and more on the keratinizing part, and on the lower lip it will often have squamous cell carcinoma if a skin cancer develops, and that's usually on the junction of that keratinizing, non-keratinizing part. I already told you that squamous cell has more propensity to go to lymph nodes, and so we do have to worry about that. And with lip involvement, we also want to be very cognizant of oral competence when we remove something and put it back together. But we want to be watching to consider indications for that lymph node biopsy. We now do sentinel lymph node biopsies, like we discussed earlier. Usually we're looking for a 3 millimeter depth based upon various studies. There are studies that mention 6, 4. I think 3 is one that I've settled on as being as inclusive to most of the people who are going to be at risk for a lymph node. And overall, 11 to 12% incidence that a lymph node will be involved. Evaluating that would allow us to add other treatments such as radiation. So here's a lady who had a lip biopsy showing a squamous cell carcinoma. This time we were going to do a kind of a one-and-done approach. I resected it, sent it to the pathologist to make sure I cleared the margins, and then did a W to Y closure. This gentleman had a basal cell carcinoma of the upper lip, and although we didn't have to worry about lymph nodes, you can see that it did lead to quite a resection, quite an area of defect, and there's just not enough tissue there to just pull it back together and close it. So I had to add tissue from somewhere else, and I wanted to use tissue that looked like for like, so I used his bottom lip, and still anchored, you can see it on the right side, still anchored to the bottom lip, it is inserted on the upper lip. 3 weeks later, I separate that connection because it's established its own blood supply, and he lived out of state. He drives back about every 6 months or 9 months for me to take a look at it. It's doing great. And he's very happy and has good oral competence. There's no muscle in that flap, but eventually muscular fibers kind of grow in and create a scar band, and there is some movement. It just doesn't quite move like a sneer like I'm doing right now. So this is the one that gets most of the media attention and is certainly where a lot of work has been done. Malignant melanoma affects 100,000 people per year in the United States alone, and that is growing at 4 to 5% per year, with up to 7,000 deaths. In stage 3 and 4, in years past in the 70s, if you had stage 4 disease, you usually had less than 1 year to live. Most malignant melanomas are found in a very thin, superficial presentation, and so there's a 93% survival in over 5 years for most melanomas. But we focus on the ones who have the higher risk, which is the ones that fell into that other 7% category. We're looking for a lesion that's often pigmented. It doesn't always have to be, but often pigmented with asymmetry of that pigmented mole, some color variation within the mole. It's growing, it's changing, and evolving over time. So malignant melanoma falls into 6 categories, and the superficial spreading is the most common, followed by probably lentigo maligna, which lentigo maligna is melanoma in the skin, and then when it goes through, it becomes malignant melanoma, which is lentigo maligna melanoma, just for providers to know that distinction, because they'll see it sometimes as lentigo maligna and then lentigo maligna melanoma, and those are 2 different things. So those are the majority. Nodular is one with a very quick vertical phase of growth. Desmoplastic forms a lot of scarring. It's actually very difficult to spot. It looks more like a scar. It's not always pigmented. Acrolentiginous is on the palms and underneath the nails, and mucosal is inside the mouth, is its own disease, its own beast. The AJCC has its guidelines. If I gave you time to look over it, you'd understand how we don't have time to go through this on this lecture. But essentially, the melanomas are broken up into thin, intermediate, and thick by the depth of their penetration, and then there's a lot of consideration given to the ulceration of the specimen. So less than 1 millimeter is thin, 1 to 4 is intermediate, and greater than 4 is thick. We then divide that up a little bit more finely and found that over 0.8 millimeters can be inclusive to concerns regarding lymph nodes and lymph node spread with the cancer. And also ulceration, which really changes the depth because you don't really know how deep it would have been originally. And then certainly any biopsies that didn't give us the depth. So they had a positive deep margin. This staging slide will also show that the number of lymph nodes that are involved is important. And what we find about melanoma is the lymph nodes can be involved without seeing gross disease, which means a big lymph node in the neck. So they can be present as a metastasis in lymph node, which can change all the staging and have no palpable or visible abnormalities. And therefore, we discuss in a minute sentinel lymph node biopsying to try to evaluate that first lymph node that comes out of the lymph node basin from the area where the skin cancer is present. The lymph node status changes greatly the staging of the staging of their disease. So positive lymph node, multiple lymph nodes, in transit or satellite metastases. Satellite metastasis is a lesion of melanoma that has jumped within 2 centimeters of the original lesion, and you see like another dot within 2 centimeters of the original lesion. Or an in transit is somewhere between a lymph node and that area, but away from the original tumor by more than 2 centimeters. And all these are considered in the staging. And really, most of the advances in treatment for melanoma come in the stage 3 and 4 disease, which I'll go through in a minute. So treatment of melanoma is surgical. We cut it out. Typically, some studies have shown in Mohs micrographic resections, and it's not typically treated with Mohs, but Mohs micrographic resections have shown that kind of the optimal distance for resection is about 12 millimeters, but somewhere between 1 and 2 centimeters typically. And we do have a version of Mohs micrographic surgery where we resect it, wait 24 hours, stain it, leave the wound open, and then re-resect it. But generally, cutting out is the principle and with a 2 centimeter margin. But we need to know if it went to any lymph nodes, because I told you it'll go to a lymph node and not show an abnormal lymph node. So surgery is the mainstay treatment, then biopsying a lymph node to make sure that a lymph node isn't involved. If it is greater than 0.8 millimeters in depth, or it doesn't have the presence of ulceration. Or if it does have the presence of ulceration. T1B is kind of an area which is that 0.8 to 1 millimeter depth, where you have the talk with the patient to see if they want to do the sentinel lymph node. But really, we push for that 1 to 4 millimeter thickness to be the depth where the sentinel lymph node is important. And that's based upon a study done called the multi-selective lymphadenectomy trial, which was done in 2005, which showed that these sentinel lymph nodes not only change their prognosis and change our treatment, but also improve disease-free survival for patients. So we do a sentinel lymph node when we find the tumor, if it meets those indications. And how do we do that? We inject them with some radioactive dye, technetium-99 sulfur colloid, 0.2 mLs, usually tangentially placed into the skin so that there's no collapse of the lymphatics. And we use a radioactive probe called a gamma probe to measure the radioactivity counts per minute in order to make sure that we have the lymph node of biggest concern. Then we use a single positron emission CT to localize the lymph nodes so we can have a minimally invasive approach. So here's a lady who had a melanoma in her right temple. It's that red dot in the middle of all my markings. And it was biopsied and shown to have about a 1.2 millimeter depth. And so we had her injected with the technetium-99 sulfur colloid. We marked out 2 areas of lymph nodes, one of which was in the parotid gland. And then I planned out my resection as well as the advancement flaps. And I used that lower flap, which is flap meaning raising the skin. I used that lower entrance area to access those lymph nodes in that region. So if we get somebody who has melanoma, and we resect it, and it was of a thickness under 4 millimeters where we think we have the best effect to evaluate the sentinel lymph node. If we get a sentinel lymph node back that doesn't have any abnormalities in it, then we closely follow these patients. We do serial ultrasounds and watch them closely. But the ones who have a positive lymph node, or more than one positive lymph node, or even evidence of these in-transit or satellite metastases, they are now entering into a little bit different stage of the disease. And at stage 3 and 4 disease, we have systemic therapies that can help them. And this has really changed everything for melanoma, at least for now. There are 2 types of therapies, and they're both immunologic type modulating therapies. The programmed cell death receptors and the cytotoxic T lymphocyte antigen receptors are 2 receptors that affect a signaling pathway that tells our T cells to get active or to kind of mellow out. And then BRAF and MEK are 2 other genes that help the signaling pathway called the MAP kinase pathway, and they also activate cell turnover. And so we found that these patients had some genetic defects in some of these regions. And so when we have someone with advanced disease, we're able to actually turn up their cells to go attack and kill their cancer. So after starting these therapies, we've had the ability to raise that 1-year kind of very, very morbid outcome of most people dying within 1 year for stage 4 disease to up to 50% of people living 5 years with some very advanced disease. So the first therapy, when we have someone who has positive lymph node metastases and the melanoma has advanced, is the BRAF and MEK inhibitors. So we take the melanoma tissue, we send it for testing. They look for a BRAF gene mutation or a MEK gene mutation. And then if they have those mutations, they'll be a candidate for 2 sets of drugs, either dabrafenib and trametinib or vemurafenib and cobimetinib. They together have about a 30 to 40% 5-year survival when people are in advanced disease and they're given these drugs. And so they've had quite an effect in allowing people to live longer, and some people having complete remissions of their disease. The second combo, vemurafenib and cobimetinib, are pills, which is kind of nice, but they have their downsides. I'll talk about those in a second. The checkpoint inhibitors include the programmed cell death inhibitors and the CTLA inhibitors. That includes ipilimumab, nivolumab, and pembrolizumab. And the different studies have shown different efficacy of each of these things, and they're usually chosen by the oncologist. But for stage 3, often nivolumab, Opdivo is used, and for stage 4, a combo of Yervoy and Opdivo called nivolumab and ipilimumab. But what they all have is the potential of kind of labeled immune-related adverse events. And I kind of liken it to graft versus host reactions with people who've had bone marrow transplants. Their body is turning on them, and they're having a basically severe autoimmune reaction because they've turned on these T cells, and now they're not just attacking the tumor, they're attacking other parts of their body, their skin, their organs, endocrine. So that's a small percentage, but enough of a percentage that it leads to a lot of people not being able to complete the treatment. So I think the future is going to be trying to find drugs that do this without the severity of those adverse events. Because if they have that adverse event, then they have to go on immunosuppressives, which basically make their disease have the ability to grow even faster. So it's a great advance, and they're certainly standard of care for right now for those advanced diseases, but there's more work to be done. And I put down there in the 1970s, dacarbazine, the original chemotherapeutic given for systemically spread melanoma, only worked on 10% of patients, and the FDA approved that. So I think we've come a long ways. Next, we're going to talk about cutaneous sarcomas. This is a very small percentage, but when you deal with it, you can see it really affects people quite dramatically. The most common I see would be dermatofibrosarcoma protuberans, DFSP, and atypical fibroxanthoma. I do see occasional pleomorphic dermal sarcoma, also used to be known as malignant fibrous histiocytoma. And then these other two, leiomyosarcoma, angiosarcoma, you'll see those occasionally, and they're very, very severe diseases advance quickly. But DFSP will be the first one we talk about. Typically with these, as the sarcoma will take very wide margins and often consider some adjunctive therapies. So here's DFSP. This was a gentleman who had been in the military and 10 years prior had a doc look at a lesion on his face. It looked fine, felt it was kind of hard, and he said, well, that's fine. That's just a little skin thing, you'll be fine. 10 years later, it had grown to what I marked out here. So you can't see it, but I've marked out where I felt the borders of this kind of hard indurated skin that clearly wasn't infected. Let me see if I say anything else here. Yep. So with him, I said, well, we'll take a biopsy and we'll also do this intraoperatively and I'll just resect it. And so I took the biopsy, and immediately the pathologist said, this is a sarcoma, and it's at the edges of everything you resected. So then I did another resection, and it just kind of heralds to what happens with these cutaneous sarcomas, is the area of involvement is much bigger than the originally marked area. And so you can see on the top left, the area of involvement, and then my planned reconstruction, which was a rotation flap with a little Z-plasty. My Z-plasty isn't as pretty as I would have originally liked it to be, but it's certainly, I saw him back just a few months ago, and he looks great. And of course, he doesn't feel like he would rather not have had to go through this, but I think it's healed quite well. Atypical fibroxanthoma is kind of an early version of pleomorphic dermal sarcoma. It's usually a little bit more benign. Like DFSP, which I didn't mention, doesn't usually go to lymph nodes. This one rarely goes to lymph nodes. Usually an older person, pops up really quickly. It's really ugly looking when it comes up, and you have to take a 1 centimeter margin, but rarely goes to any lymph nodes. So we're going to change from the other sarcomas into kind of its own category, Merkel cell carcinoma. It's a neuroendocrine skin tumor. It's really likely generated from the Merkel cell polyomavirus, as that's found, that viral genome is found in 80% of all these skin cancers, and it's extremely aggressive at times. Surgical excision is the mainstay treatment with a fairly good margin, 1 to 2 centimeter margin. And when it's greater than 1 centimeter, we definitely want to evaluate the lymph node, as that can be a significant change on its treatment plan. So typically it will involve a resection with a sentinel lymph node biopsy. If the lymph node is positive, then you may decide to do a lymph node dissection of the neck, but radiation is actually shown to be more efficacious than the neck dissection and neck dissection by itself. So commonly, it'll be offered to the patient to do a neck dissection, which means removing the lymph nodes in the neck that's involved with this. But radiation is really important of that nodal basin, and then we always radiate the original primary site. Chemotherapy has been given for this. Recently, nivolumab, which is one of those checkpoint inhibitors, has shown a pretty good response rate. I had a patient last year who was given this, as a neoadjuvant therapy, an upfront therapy, and we didn't have to do lymph node dissection or neck dissection, even though he had positive lymph nodes, because it all regressed. Haven't seen him back since, so I think he's doing well, actually. Okay, this is the kind of opposite end of the spectrum. This is a patient of mine who had very severe skin disease, had recurred despite someone else's previous attempt to remove it. I marked on the bottom the resection area, the neck dissection, and the pectoralis flap I performed. My wife thought the pictures probably weren't necessary for this slide, so I left them out. But I can tell you it was quite a dissection, a lot of work to try to help this wonderful gentleman, and eventually, time later, he did succumb to disease. So in conclusion, for skin cancer, prevention is the best treatment. Avoid tanning booths, period. Squamous cell needs to be given quite a bit of attention because, again, it has almost an equivalent loss of life to melanoma, but it just, sometimes it's like, oh, that's the squamous cell, it'll be fine. You still need to give it a lot of attention. Melanoma's advanced disease has quite an advance in treatment, and so I don't think it quite has the same stigma of being a death sentence that it did before. And Merkel cell is its own category. Thank you. Okay.
Amanda asks, if you have clean margins when resecting via Mohs surgery, why is sentinel lymph node biopsy necessary?
So sentinel lymph node biopsy primarily is reserved for the melanomas. And we actually don't do Mohs micrographic surgery at the time of resection for the melanoma. We'll do the resection in the OR with a very wide margin and a sentinel lymph node biopsy at the same time. And they're injected in the morning. They come to the OR. I resect and do the lymph node biopsy that day. The squamous cell is a little different. And so if you get a biopsy of a very large squamous cell, and it has maybe a poor histologic variant, and if you did a full thickness, you can show some fatty invasion or perineural invasion, you kind of have a clue that this is a little bit more than just your typical Mohs micrographic surgery. And typically, I would probably resect those in the OR with a sentinel lymph node biopsy. So Mohs micrographic is really, primarily its workhorse use is in basal cells and squamous cells that aren't quite in those categories, if that answers the question. All right, thank you.
Hello and welcome back to our second session of our ENT update. Over the break, we did get a question about a COVID complication as far as an otolaryngic manifestation. Dr. Ryan Rehl has a whole talk discussing exactly those questions. So if you don't answer your question during that talk, please enter that into the chat box so Dr. Rehl can address that at the conclusion of his talk. So with that, I will introduce our first speaker for the second session, Dr. Dan Hurley. Dr. Hurley is a founding member of Valley ENT, currently serving as its president. Dr. Hurley practices comprehensive otolaryngology with a focus on nasal obstruction, sinonasal disorders, as well as pediatric ENT. Today, he will be talking to us about one of his passions, nasal obstruction. So with that, I'd like to welcome Dr. Hurley to the podium.
Hello, good morning, I think still. So my name's Dan Hurley, and I'm going to talk about nasal obstruction, which I'm reasonably passionate about, as I've told my kids. So briefly, why does it matter? What are the causes, and what can be done? You've seen the acknowledgement. I don't have any disclosures. So our objectives for this talk. We're going to review the differential diagnosis for nasal obstruction. I'm going to basically take you through what I would present someone with if they came in as a patient to try and frame the problem. We're going to identify the areas of anatomic obstruction in the nose, and then we'll describe the treatment options available to patients with nasal obstruction, both from a medical and a procedural standpoint. And you really can't separate the two, because the problem is if you don't look at the medical part and you do the procedural part, you'll have people who are frustrated. So why does it matter? Multiple things: sinus and pulmonary health, quality of life, dentition and facial development, which is becoming more mainstream in the last 10 to 15 years and is fascinating, exercise physiology, and then obligate nasal breathers. which I learned when I was researching this talk. Horses are actually obligate nasal breathers, and then also babies. So nasal airway, sinus and pulmonary health. Your nose is your filter. So if you have to breathe through your mouth, especially in the desert, you're going to have more particulates in your lungs. Obviously, that is not ideal. The nose and the sinuses are a repository for nitric oxide, which could be the subject of an entire talk, so we won't go into that. But that has vasodilatory effects that can be positive. And there's multiple studies out there, but we have seen that nasal breathing has been associated with a diminished exercise-induced bronchospasm, which makes sense. If you're someone who's reactive or has more propensity for asthma, if you're not using your filter, you are going to have more issues. So nasal airway and sleep quality. This is, I believe, Hypnos, who's the god or goddess of sleep. I thought it was kind of funny because they're missing their nose, so I don't know how they're sleeping well. But mouth breathing results in a diminished dry mouth and diminished sleep quality. And we've all experienced this when we have a cold or upper respiratory infection. You wake up, you're getting a glass of water, but there are not a lot of people who have that day in and day out, and it does impact their ability to get restful sleep. In the ENT world, we know with sleep apnea treatment, referencing Dr. Weiner's talk, CPAP is the gold standard for the treatment of sleep apnea. And if you can't breathe through your nose, a lot of people have more difficulty tolerating it, just because it takes a special person to tolerate a full face mask. So we found that if we improve people's nasal airway, they actually sometimes tolerate CPAP better. And then in some patients with nasal obstruction, it can actually affect the severity of their snoring or sleep disordered breathing. I kind of have a love-hate relationship with this one. When it works, it's great, but it's very difficult to predict in any given patient whether or not their sleep issues are going to resolve if you open up their nasal airway. But we'll come back to that when we talk about patient homework. Facial airway, facial airway. Nasal airway and facial development. So airway stenosis is more common in mouth breathing. For years, we've all known, okay, you can pick out that child as having large adenoids because we see that they have a long, narrow face. If you look inside their mouth, they have a high arch palate. But as that's become, a little more mainstream, we're seeing more and more people from the dentist or orthodontist who are identifying children who can't breathe through their nose. They notice that the mandible and maxilla rotate back and down, and this has impacts for breathing, of course. It has impacts for orthodontic issues. There's evidence that this can probably not only impact orthodontic issues, but probably also impacts the propensity for adult onset sleep apnea because of the position of the jaw and the tongue based on the way the face grew when someone was much younger. So I'm sure over the next 20 years that'll become more and more apparent. So then there's mainstream attention. I've learned so much about the nasal airway from the mainstream because you come through residency and whatnot, but you're not thinking about some of the other things. There's a great book out there, Breath, which is a good listen or a read that kind of goes over why it matters. There's all kinds of interesting things on the market, nasal cones, breathe right strips. There's a subset of people who think you should tape your mouth shut, and there's actually mouth tape. But regardless, it's gotten more mainstream attention in the last few years, and there's plenty of interesting information out there. So what are the causes? When we look at the causes for nasal airway obstruction, we're going to focus on the anatomy or what we as ENT doctors can change surgically, but we have to talk about everything. So I split it up into infectious, which would of course be sinusitis. If you have a sinus infection, we have increased nasal congestion. Inflammatory, of which of course infectious is a subset, but we all know allergic and non-allergic rhinitis, and there's other less common problems that can cause you to obstruct your nasal airway. And then we move to the anatomic. So we start with polyps or nasal growths. Those would be not what I'm focusing on, but they're out there. And then anatomic variations. So that'd be your deviated septum, your turbinates, your nasal valve, in kids, adenoids, sometimes a very large concha bullosa, which we'll go into. And I basically compare this to a Venn diagram, which I think was geometry, but it's the circles that overlap and you're not sure how much. And you have to really think of these as three components, but you don't know for sure how much each component is impacting the others. So, anatomic nasal obstruction. There are three main areas that apply to everyone. First is your nasal septum. It's made of bone and cartilage, it's the midline wall. Then you have your inferior turbinates. It's the side-to-side variability. If you've had a cold, you lay on one side, you can't breathe. You go to the other side, you can't breathe. Those are your turbinates. And then your nasal valve, which is the airflow bottleneck. And then we also have the issues that we'll just go over very briefly: adenoids for kids, concholosa, and then we have to make sure you don't have polyps or a mass. So before we get into that, this is my physics review. I put this disclaimer on when I made the slide, and then just last night I was told I spelled Poiseuille's law wrong, so we fortunately got to fix that. But there are two principles in physics that apply to your nasal airway that you're using all the time. The first is Bernoulli's, and Bernoulli's basically says that with increased flow, it's associated with an inward pressure. So I always tell people to picture a tent and stick a vacuum cleaner in it. And when you stick a vacuum cleaner in a tent, the faster or more powerful the vacuum cleaner, the more the tent wall is going to collapse. So if you think of your nose the same way, the harder you have to breathe because of other obstruction, the more likely you might have some collapse. And then Poiseuille's law is basically a little goes a long way law, which flow is radius to the fourth power. So all you need is an extra millimeter or two, and you can really change someone's nasal airway significantly. So, taking these step by step, the nasal septum. It is the midline wall of the nose. It separates the right from the left. So it's a fixed obstruction. So if someone says, I always can't breathe on my right or I always can't breathe on my left, you can make a reasonable guess that they probably have a deviated septum to that side. It is made of bone and cartilage. The cartilage is up front, the bone's in the back. Cartilage actually usually means more with respect to obstruction because the radius of the nasal airway is smaller there. So I showed you CTs of the bone because CTs don't show the bone very well. But on the upper slide, you see the arrow. That's a septal spur, which obviously pushes the septum over. And then on the lower slide, you see a deviation to the right. That's the nasal septum. So it can be congenital or post-traumatic. Most of us have some deviation to our septum. It doesn't mean it needs to be repaired. It really counts on how much is it making a difference for you. Next, your inferior turbinates. So you have 3 turbinates, well actually 6 because you have 3 on each side. Inferior, middle, and superior. Traditionally, only inferior is supposed to be erectile tissue. It gets bigger and smaller with temperature changes, moisture changes, allergies, all kinds of weird stuff. We all understand where our turbinates are, even if we're not familiar with the term, because again, when we've had a cold, we're laying on one side or the other and it flips. Regulates humidity and airflow. They can be reduced but not resected. Specifically, if you remove your entire inferior turbinate, you'll have a dry, crusty nose, which of course obstructs your airway. Simplest way to remember inferior turbinates is if you've ever tried Afrin or Sudafed, Afrin is your inferior turbinates. So we have a CT scan, and we can see the inferior turbinate is the oblong hot dog type structure. And then right under that is a drawing of the inferior and middle turbinates, with the inferior one, of course, being the area of interest. So the nasal valve. It's the narrowest part of the nasal airway. It's comprised of the angle between the nasal septum and the lateral nasal wall. Remembering our physics, the faster the airflow, the more the inward pressure. It's affected by age because our skin soft tissue envelope thins as we age. It's affected by the narrowness of the nose. Obviously, post-dermatologic surgery for skin cancer in the nose can affect this as well. And it's also affected by whether or not you have turbinate hypertrophy or aseptal deviation, because the more underlying obstruction you have, the harder you have to pull, which is going to make this collapse more. So the easiest way to remember this is the breathe right strip effect. So the diagrams there basically are my artistry is demonstrated up high, which is limited, but I'm trying to show you that the wall will collapse the harder you breathe. And then down low, that's my daughter's drawing of somebody's skull. So that's pointing to where most of us will obstruct. So when you breathe in, if you look in the mirror and do, you'll see that collapse right there, and that's your nasal valve. So other anatomic considerations. These are primarily the you don't want to miss these. You don't want to find out you shrunk somebody's turbinates or you fixed their septum and they had either ginormous adenoids that obstructed the airway and you've done a procedure and they're not happy. Very similar to the way you don't want to miss someone's bad allergies thinking that you're going to make a difference just by improving their anatomy. So the concha bullosa is an aerated middle turbinate. In the lower right, you'll see the inferior turbinates, and then right above them you see two black dots. Those are large concha bullosa. There's a small concha bullosa in the upper left with a large blue arrow. And those in most people, which are present in 15% of the population, don't do anything at all. But if you have very large ones, it can contribute to your obstruction. Second issue would be something like a nasal polyp or a mass. That's an endoscopic view on the lower left of a polyp or a mass. It's the reason why you want to make sure we do a thorough exam, and for me at least a nasal endoscopy or a CT scan before I operate it in somebody's nose, because once again, you don't want to fix a bad septum only to find out you've still got an issue because you didn't investigate everything. And that adenoid enlargement, the top middle picture with the blue arrow, those are the adenoids. So if those are large, they'll narrow the nasopharyngeal airway, which is the black air column. In this slide, there's some mild narrowing. In a younger kid, 3 to 5 years of age, you can see complete obstruction of the nasal airway. So, clinical evaluation, what do we do? Most people in the primary care environment are probably looking in the nose with a otoscope, with a speculum, totally fine. However, if you want to get a great nasal airway exam, you can get a nasal speculum, which is that metal piece pictured there, and a bottle of Afrin, or if you're going to use your otoscope, if you keep some decongestant around, spraying that in the nose will make them significantly more easy to examine, and also gives them an idea of how much their nasal airway means to them. And then, of course, outside of primary care, we have nasal endoscopes in the office that we use to look in people's nose, and CT scanners if it's required. Interesting thing is history means a lot, because history can tell you which side is worse. It can tell you if it fluctuates, it's probably the turbinates. And with a good history, you can even usually get nasal valve issues, meaning that nothing else helps. So, physical exam. On the left side of the screen here is what you will see with an otoscope to some extent, but certainly with a nasal speculum. So on the right picture, or the left picture, anatomic right, is the right side of the nose. So you see what's staring at you is the nasal septum. There's a small spur. And then on the left side of the screen, that's the inferior turbinate. And then the picture next to it is the left side of the nose. So now the septum with another little spur is sitting there, and then the inferior turbinate's sitting right there. And if you were to spray Afrin in this person's nose and examine them a minute later, you'd see much more black or much more airway. Occasionally, people will mistake that inferior turbinate for a polyp. So when you're trying to diagnose that, once again, decongestants will shrink turbinates, they won't shrink polyps. So this is a quick video of nasal endoscopy, which for me, I do in most people. Everybody has nasal hair, so that's normal. We see the nasal septum on the left side of the screen, inferior turbinate on the right side of the screen. We're going through the nose. Middle turbinate is right here. Middle meatus is on the right side of the screen. That's where our sinuses drain from. You're looking at the posterior aspect of the inferior turbinate. Now you get to see the opening of the eustachian tube. Straight ahead is where the adenoids sit. These have resorbed in this person. We usually take a quick look around the corner to look at the vocal cords just to make sure that we're not missing anything. And this is a procedure we do in the office. It takes 30 seconds to a minute. We apply some topical anesthesia. It is not as bad as one would think, and it gives us a lot of information. Take a quick look on the other side. We're not going to put them through it all the way. You will, however, see that there's a septal deviation on this side. So right in front of us, there's that septal deviation. You can see it pushing in on the turbinate. So, patient homework. Anyone who's considering having a nasal procedure, this is very important. I always tell people, look, when you see me in the office, I can do an exam, endoscope, I can talk to you, and I have a pretty good picture of your nasal airway. But you're a movie. And so we really need to know what's happening during the movie as opposed to just that one snapshot to decide whether or not there's making a difference. So phase one of homework that I give people, which can easily be done in the primary care arena, is that even if you don't think you have allergies, you should do at least a 2-week trial for the inflammatory contribution. So you owe it to yourself to do a 2-week trial of a topical nasal steroid, such as Nasacort or Sensimus. These are now available over the counter. They don't work immediately. They build over a couple of weeks. I recommend a 2-week trial of an antihistamine, and then using some nasal hygiene, which is actually more important in Arizona than other places because we have a lot of particulates and dust and it's dry. And the reason this is important is, first, it might tell them they have more allergies than they think, and maybe they want to pursue that or get tested. Second, if this works, maybe they don't need a procedure. And third, a procedure isn't necessarily going to replicate most of what these will do. So if someone has a severe problem and it migrates to a minor problem after this trial, then they might not need a procedure even if they have some anatomical obstruction. So this is a busy slide, but phase 2 of the homework is for the anatomic component. This is the in vivo assessment. So we have to remember afrin represents an inferior turbinate reduction. So disclaimer, afrin should only be used temporarily. There are certain people with blood pressure issues or heart issues who should not use it, but it is great because there are very few procedures we have to offer where you can ask patients if they want to try it before they decide, and afrin lets you try a turbinate reduction. The difference between the right and the left nasal airway, once afrin is in place, predicts your septal deviation. So if I spray afrin in my nose and I say, well, now I can breathe better on the left than the right, I can predict, oh, okay, that's my deviated septum to the right. And then if there's still nasal obstruction, pop a breathe right strip on, or you can get some nasal cones, and that will, quote, fix your nasal valve temporarily. I often tell people to do this during sleep or exercise because this is where the most significant components are seen. This is helpful for some people who may not even realize that nasal obstruction is contributing to their problems. And once someone has been through this, I'll have a brief review with them and say, okay, what parts do we need to fix, or do we even need to fix anything? So once we've gone through all that, we've excluded that, this isn't allergies, this isn't an inflammatory process, you don't have a polyp, and someone decides I need to improve my ability to breathe, we can look at any one of those 3 components and help people with that. And just because someone has a deviated septum or has a nasal valve with turbinates doesn't mean you need to do everything. Some of that's based on the severity of the problem, how much motivation the patient has, and how much time they have. So the easiest one, or the lowest hanging fruit, is a turbinate reduction. So turbinate reductions can be done alone or in conjunction with other procedures. These can be done in the office. In the office, you have to be willing to put up with, us putting some numbing medication in your nose and injecting numbing medication like a dentist would. They can also be done in the OR. There's a 0 to 3 day recovery depending on the modality. On the upper left, there's something called a microdebrider. Microdebrider is kind of a roto-rooter. It sucks in a little 2 to 2.9 millimeter piece of tissue and then rotates 5,000 times a minute. So I compare this to taking a big Hebrew National hot dog and turning it into one of those little tiny ones. That can be done in the office in the OR. So little bit can be disconcerting in the office just because of the noise and vibration in your head, but people get through it fine. Then on the top right is radio frequency. Basically, you're heating and destroying the tissue so it will not become erectile tissue. So remember that inferior turbinate's erectile tissue. If we turn some of it into scar, it won't get as big. That's very easy to do in the office. So septoplasties. When people have septoplasties, typically these are done in the operating room. They take about an hour, outpatient procedure, go home the same day. 2 to 5 day recovery. It's highly variable. Some people you operate in the nose and they're ready to go the next day. Some people say that was a really rough sinus headache for a week, and you never know who's going to be who. There aren't any external incisions for a septoplasty. Everything's internal. It addresses the bony and cartilaginous septum. Sometimes we have to put some splints on the inside to kind of remind that cartilage where to sit for a few days. During that time, some people will not be as enthusiastic about their final result as
we like. Once we pull them out, should do well. There is a procedure that involves putting a balloon in the nose, not balloon sinuplasty, totally different thing, to try and straighten that septum that can be done in the office for someone who doesn't tolerate general anesthesia. This is one of those procedures, when they first came out with it, I looked at it and said, I just don't think it's going to work. I will say that after doing it a few times, it works better than I would have expected. So we may see a little bit more of that in the coming years. Valve procedures. This is a whole talk in and of itself. So the gold standard for repairing your nasal valve, or the breathe right effect, is functional rhinoplasty. So that means opening up the nose, rebuilding the framework, not to make the appearance different, but to apply more structure. So, my vacuum cleaner in a tent, I say visualize putting a thing of cardboard up the sidewall of the tent. Now your vacuum cleaner is not going to collapse it. That would be what a functional rhinoplasty is. Even though it's the gold standard, it doesn't always work as well as we would like. And that can involve spreader grafts or alar batten grafts, but we won't go into that. There are some procedures that are directed at the nasal valve that are a little less invasive. They can be done in the office or in the operating room. There's something called Weiner, which is basically trying to stiffen that nasal sidewall. That is something that is very easy to do in the office with local anesthesia. There's something called Latera, which is essentially an internal breathe right strip. It works quite well. Sometimes you can feel it or even see the implant. And of course, any implant has the propensity to extrude. Insurance coverage can be somewhat of a challenge for those last two procedures. So finally, just because we can doesn't mean we have to. So really, we're making this decision by patient preference and quality of life. Have conservative measures failed? And there's kind of two components to that. First, not everybody who has a septal deviation and turbinate hypertrophy needs something done. Second, there's a lot of people running around that have nasal obstruction and don't realize how much it's impacting their life. For example, you might see somebody in the office for an ear complaint. You happen to see a severely deviated septum. You talk to them a little bit about how it might be impacting them. And 3 months later, they're back saying, I didn't realize this was the issue. Now I want help. So anyway, that is my little algorithm for nasal airway obstruction. Hope that helps. And that's it.
So next, it's my pleasure to introduce Dr. Ryan Rehl. Dr. Rehl is a rhinologist, so he specializes in care of diseases of the sinuses, so not only inflammatory sinus disease, brain fluid leaks within the nose, sinonasal tumors, and other similar conditions. Dr. Rehl practices at our Arizona Sinus Center division in downtown Phoenix. And today, Dr. Rehl will be talking to us about olfactory loss in COVID-19. So with that, I'll welcome Dr. Rehl to the podium.
All right, well, thank you. It's my pleasure to talk to you today about olfactory loss in COVID-19. It's hard to believe we're still in the midst of a global pandemic here. So I have no relevant disclosures to make. So these are our objectives over the next 20 to 30 minutes. I want to describe the incidence and duration of COVID-19 and the associated olfactory loss. I want to explain the pathophysiology of how COVID-19 can affect our sense of smell, and then at the end discuss some evaluation and treatment strategies. So as you know, COVID-19 presents with many common acute ENT symptoms. So these patients will present to us with cough, headache, nasal congestion, rhinorrhea, sore throat, and altered sense of smell and taste, of course. There are some less common acute ENT symptoms that they can have, including sudden sensorineural hearing loss and viral labyrinthitis, which can cause debilitating disequilibrium and dizziness. With respect to olfactory dysfunction, which will be the subject of the rest of the talk, we've had enough data come in now with the global pandemic to know that most SARS-CoV-2 infections are going to result in transient olfactory dysfunction. So when you look at the patients who have had a SARS-CoV-2 infection or COVID-19, greater than 50% of them are going to report some type of olfactory problem. So if you look at hyposmia, which is diminished sense of smell, and anosmia, which is no sense of smell. Collectively, greater than 50% of patients will report those symptoms. And when you look at parosmia, which is a distortion of the sense of smell, 11% of patients across the board that are infected will report those symptoms. It's interesting to look at sense of smell when it's objectively measured, however. So there's a good chance that if you had COVID-19 and you didn't think you lost your sense of smell, you probably did lose some. And this is an interesting study in our literature that came out in April of 2020 from Iran, 60 COVID positive patients, and they actually subjected them to an objective smell test called the UPSIT, or University of Pennsylvania Smell Identification Test. And that's a 40-item multiple choice scratch and sniff smell test. That's a validated measure of smell that we've been using in rhinology research for decades. And they found that 98% of the COVID positive patients had actually lost sense of smell on the UPSIT, or the objective smell test. Interestingly, only 35% of them were aware of that smell loss. We now have enough data to know that, fortunately, most patients who have COVID-19 are going to get their sense of smell back, usually within about 3 weeks. Paper January 2020 looked at 229 COVID-19 patients, 61% of which reported olfactory dysfunction, and nearly 80% of those people got their sense of smell back by day 16 after the infection. And now we're far enough into the global pandemic that we have meta-analyses, so we have coalescence of multiple different papers, and we can kind of coalesce the data, and we know that across the board, 60% of COVID-19 positive patients are going to experience some type of olfactory dysfunction. Fortunately, most patients will recover by about 1 to 2 months, but there's a small subset, or maybe not so small, depending on which paper you look at, of patients that will have persistent olfactory dysfunction beyond a couple of months. This is the most recent meta-analysis in our literature from the laryngoscope about 6 months ago. They looked at 27,000 patients from Europe, North America, Asia, and Australia. And they found that across the board, the prevalence of olfactory dysfunction was near 50%. In the papers that looked at subjective reporting from patients, they found that 45% of patients affected by COVID-19 reported smell loss. But again, when you looked at the papers that objectively measured sense of smell, similar to what we saw in that study from Iran, 72% of patients actually had objective smell loss on testing. And interestingly, there's a female predominance, so 61% of the patients in those studies that had smell loss were female. This is a great slide, a great graph from International Forum of Allergy and Rhinology, a 2021 paper that looked at multiple different studies following COVID-19 smell loss over time. On the left side of the graph there, you have the percentage of patients, so the rate of patients experiencing olfactory dysfunction. Across the bottom there, you have a time from the onset of the infection. So 4 weeks there initially, 5 weeks, 2 months, and it marches on out to 6 months. And if you look at the colors in the bar graphs, black is normal sense of smell, gray is hyposmia or diminished sense of smell, white is anosmia, and then the stippled area indicates hyposmia or anosmia, the papers that didn't differentiate between those two. And you'll see that at 4 weeks after the acute infection, the papers that looked at that, you'll see that about 65% of patients are reporting smell loss. As you march out from the time of the infection, the papers show that when you get to about 3 months after the infection, you'll see that about 90% of patients have recovered their sense of smell. And then 6 months out from infection, we see that about 95% of patients recover their sense of smell, which means that 5% of patients who have COVID-19 6 months out from their infection are going to still have some persistent smell loss. So who might ask for our help? If we extrapolate that data to our community here in Arizona, we've had over 1 million cases of COVID-19. So what does that mean? If we think 5% are going to have smell loss that lasts longer than 6 months, we're looking at 50,000 patients in Arizona. And just in our county alone, 34,000 patients might need our help for advice on what to do about their persistent smell loss. What are the risk factors for prolonged olfactory loss after COVID-19? So this was an interesting paper, and they found that if you had significant muscle and joint pain at the time of your initial COVID-19 infection, you had a higher chance of prolonged smell loss. If you were female, you have a higher chance of having prolonged smell loss. Interestingly, cough was negatively associated with prolonged loss of sense of smell, so somehow that was protective. This is a very busy slide, but a very important slide that speaks to the pathophysiology of COVID-19 and olfactory loss. This is from Journal of Neurochemistry. And I thought that these basic scientists did a great job schematically of explaining it. So you see on the left side of the screen, we've got just a basic representation of the nose. We have the respiratory mucosa lower in the nose. And then up at the top and back part of the nose, we've got the olfactory neural epithelium. That arises from the olfactory nerve. The olfactory nerve is the first cranial nerve. It comes off the base of the brain, tracks along the floor of the anterior cranial fossa to the olfactory bulb. And then the olfactory bulb gives off axons that penetrate through a very thin bone at the top of the nasal cavity called the cribriform plate. The cribriform plate is called cribriform because there's tiny little holes in it that allow the axons to come through and then go into the mucosa of the nose at the top of the nose, and that's how we sense odorant molecules. On the right side of this slide, you'll see a histologic representation, and what I'm going to ask you to do in your mind's eye is to flip that histologic representation upside down. So the cribriform plate part there should actually be on the top. That's just underneath the brain. And then the mucus layer should actually be on the bottom to be more anatomically correct and match the diagram over on the left side. But the components are accurate, and what I want to point out is that the olfactory neural epithelium is comprised of more than just nerve cells. So we've got the pink to peach olfactory nerves, and you can see the dilated area there. That's the cell nucleus. You've got the axons coming from the olfactory bulb penetrating through the cribriform plate. And then you have these extensions to the mucus layer in the nose, these little microscopic olfactory cilia, and those are actually the odorant detectors. So they'll detect odorants that go into solution in the mucus. You'll see a Bowman's gland there that helps secrete mucus so that mucus layer is intact and the odorant molecules can go into solution there and stimulate the olfactory cilia. And then I want to draw your attention to those yellow cells that are near the mucus surface layer. Those yellow cells are called supporting cells or sustentacular cells. You may have heard that term in the media or the literature previously. The sustentacular cells are very important. They actually support and nourish the olfactory neurons. So they're much like glial cells in the brain where they're actually protecting and supporting those olfactory neurons. They have some nourishing and phagocytic effects and help clean up cell damage. It's the sustentacular cells, not the olfactory neurons themselves, that are actually the target for the SARS-CoV-2. The spike protein on SARS-CoV-2 attaches to ACE2, which is preferentially expressed in sustentacular cells and not olfactory neurons. Also, there's a protease, TMPRSS2, which is in sustentacular cells as well, which interestingly, when the spike protein attaches to that protease, it turns on the spike protein. So it catalytically activates the spike protein, resulting in this kind of super infection of the sustentacular cells. And ultimately what happens is the sustentacular cell gets blown up and spills contents, attracting inflammatory mediators. And the olfactory neuron then is kind of naked without its supporting sustentacular cell, and that's how our sense of smell is disrupted. So it's not actually the olfactory neurons in most cases that are getting killed off, it's those supporting sustentacular cells. And that kind of makes sense when you think about what happens to patients clinically, where they lose their sense of smell for a matter of a few weeks and then recover it. So if they were actually having olfactory neuron death, it would take much longer to recover sense of smell. We know that post-COVID-19, there's a tremendous amount of inflammation in the olfactory tract. This is a study done where they looked at biopsies from COVID patients versus control patients. They did ELISA of the biopsy specimens, and they found that there's actually an increased level of TNF alpha in the tissue of COVID-19 infected patients at the olfactory neuroepithelium. TNF alpha is a very potent inflammatory cytokine that's produced by macrophages and monocytes, and that's responsible for signaling that can ultimately lead to necrosis and apoptosis, which may be active in the patients who ultimately have the prolonged smell loss. So what is the fallout from olfactory loss? Well, technically, these patients really do have a disability. So if you don't have your sense of smell, you are in harm's way for sure. You can't detect spoiled food. You can't smell smoke, and there may be a fire in your home. You can't detect a gas leak. And so we do worry about patients in that regard, but what is a more practical concern for me when I'm seeing these patients is depression. Olfactory loss is strongly associated with depression. If you look at the literature, the psychiatric literature, the rhinologic literature, olfactory dysfunction can even predict development of depression in older adults. There are a number of neuroanatomic connections that link our olfactory and our limbic systems, and some experts argue that olfactory loss is actually a surrogate marker for depression. So how do we evaluate these patients when they come to see us? We know that most patients now, looking about the beginning part of the talk, most patients who have COVID-19 are going to have some olfactory dysfunction. We know that fortunately most patients do get it back, but there's this 5% that go on to have prolonged smell loss longer than 6 months. Well, we want to consider all the causes of smell loss, even when we're seeing a COVID-19 smell loss case. Rhinitis, of course, allergic and non-allergic rhinitis can cause loss of sense of smell. Sinusitis can cause it. There are post-traumatic forms of smell loss from blunt head trauma, nasal trauma, maxillofacial trauma. There are post-surgical causes of smell loss, neoplastic, so patients can get tumors in these areas like olfactory neuroblastomas and meningiomas. Neuroinflammatory causes of smell loss, so losing your sense of smell can sometimes be the first symptom of Alzheimer's dementia. Normal aging, so all of us are going to eventually have olfactory dysfunction as we age. It's more common in males. There are congenital causes of smell loss where the olfactory tract never properly forms. And then, of course, what we're talking about is post-viral anosmia or post-viral smell loss, which is really a neuropathic problem where there's a problem with the nerves. And we've been dealing with that for over a century as a specialty. We know that many different viruses can cause post-viral olfactory loss: influenza, parainfluenza, rhinovirus, and previous versions of coronavirus as well. Practically speaking, the clinical evaluation of these patients is really centered upon the history. The history is the single most important component of the clinical evaluation. Getting that history that they had an acute viral illness, tested positive for COVID-19, and lost their sense of smell. You want to do a thorough exam on these patients as well. In the primary care clinic, that would mean performing an anterior rhinoscopy, and you can do that just with the handheld otoscope with an ear speculum on it, looking up into the nose. It's very handy to have a nasal speculum in your primary care clinic. If you can get you can order those easily online, and those help dilate the nostrils so you can get a better view inside the nose, looking for infection and large polyps. In otolaryngology, we cheat. We have a lot of fun toys and tools and instruments in our practice, so we're going to perform a nasal endoscopy and get a really good illumination of the nasal cavity and a deep inspection of the nasal cavity. Imaging is generally not required for post-viral olfactory dysfunction. You can get a CT scan if you suspect that there's chronic sinusitis or some other mucosal inflammatory thing going on in addition to the COVID-19 neuropathic smell loss. And of course, you'll want to get an MRI if you suspect a mass or some type of other neurologic, or they present with other neurologic symptoms. And then, of course, at any time along this pathway, if you need help, consider an ENT referral. We're always happy to help out and point the patient in the right direction. So with respect to primary care clinical evaluation, there were some nice, handy recommendations that came out of the UK. So the British Rhinologic Society actually published a paper for their primary care providers there, and they recommend that you confirm the COVID-19 infection on the history, evaluate the patient for other neurologic symptoms, and if the loss of sense of smell has been present less than 3 months, they actually recommend just treating that patient in your own practice, and we'll kind of get to the specifics of how that's done. If the loss of sense of smell has been present greater than 3 months, they recommend referral to ENT, or referral to ENT if there's loss of sense of smell greater than 6 weeks with other nasal symptoms. So this is kind of my treatment preview. I put my little spin on it, and I'm going to go into this in more depth here. But when I'm treating these patients, and what I would recommend to you is treat any rhinitis or sinusitis that you can identify. So kind of get the low-hanging fruit out of the way. If they have allergic rhinitis that's comorbid with their, post-COVID-19 smell loss, let's just treat that inflammation, get it out of the way. I strongly recommend olfactory training because there's strong evidence that it can help patients. I recommend budesonide irrigations for these patients. So that's actually a nasal rinse or a nasal lavage that they'll do twice a day with a topical steroid added to the saline. There's moderate evidence to tell us that is helpful. And then I liberally recommend omega-3 fatty acids for these patients as well. There's not strong evidence, but omega-3 fatty acids have been applied across the neural axis, and there's multiple papers that support its benefit in various types of neuropathic injury and dementia, things of that nature. So there's weak evidence in our literature, but very low risk, so I feel comfortable recommending it. Olfactory training, so what is that? So that's really the mainstay of treating these patients. It's also called odorant exposure therapy, and it really exploits the ability of the olfactory system to remodel. So the olfactory system neuroplasticity is what allows this to work. It's found to be beneficial in post-viral, post-traumatic, and age-related olfactory dysfunction. You do have to counsel patients, give them realistic expectations. Only 20 to 60% of patients are going to get benefit with olfactory training, but it's certainly better than nothing when you look at the literature. Olfactory training protocol. So the specific protocol, this is one protocol that was published by Zara Patel and her colleague. She's a rhinologist at Stanford. And it's recommended that patients go out and get 4 different essential oils. We recommend rose, lemon, eucalyptus, and clove. You have them hold the essential oil under the nose and perform deep, slow nasal respiration for about 15 seconds. Put that one down, pick up the next odorant, and do the same thing for 15 seconds with the next odorant. We ask the patients, it sounds corny, but we ask the patients to focus on the memory of that odor, to help connect those synapses in the brain. We have them do this BID twice a day for 6 months. And then in an ideal setting or an academic practice, you're going to want to get baseline objective testing of their sense of smell with the UPSIT or a similar validated smell test, and then a follow-up at 6 months. It's not always practical in busy ENT clinics or a primary care setting. This is the olfactory training instructions that I give to our patients at our Valley ENT division in Central Phoenix, and I included it in the syllabus so you can have and use that for your patients. So olfactory training, it may sound like a bunch of hocus pocus. How can possibly smelling an essential oil bring back my sense of smell? Well, there's actually some really cool stuff going on in your brain when you do olfactory training. And this is an interesting study where they took normal volunteers. So these weren't patients who had smell loss. They just took normal volunteers, did MRIs on them, had them do smell training with the odorants, and then did follow-up MRIs on them. And what they found is that they actually got increased cortical thickness in the right inferior frontal gyrus, the bilateral fusiform gyrus, and the entorhinal cortex. So the olfactory centers in your brain actually got bigger in these patients after just olfactory training. There's some very compelling functional MRI data in patients with olfactory loss who have been subjected to olfactory training as well. So in the image on the left is a patient with olfactory loss prior to doing a course of olfactory training. And what's happening here in the functional MRI, this is a representation of the areas that lit up on the functional MRI when they were smelling something. And you can see that there's this kind of scattered pattern of synaptic activity all over the brain. Post-olfactory training, when the patients smelled the odorant and had functional MRI after their course of olfactory training, you can see that there's this coalescence of of the signal, so this coalescence of the synaptic signal. So now it's very focused in an olfactory center in the brain called the piriform cortex. So there's definitely something going on here, and it's fascinating, but that speaks to how it works. What about the clinical evidence? 10 studies at the last time I searched looking at the evidence for olfactory training. 4 of them were randomized controlled trials. Now, all 10 of these studies did show benefit with olfactory training. 4 of the studies compared olfactory training to no treatment at all, and all 4 showed that olfactory training was superior to just letting the olfactory loss run its natural course. And there's better outcomes if you can get to these patients within 1 year of their smell loss. What about systemic steroids? That's a question that often comes up in my clinic. Will steroids help with my smell loss? A lot of this, we don't have good data with COVID smell loss yet. We're extrapolating a lot of this advice from pre-COVID, post-viral anosmia data that we have. There are 6 studies. None of them were randomized controlled trials comparing a systemic steroid versus control. So we don't have great evidence to suggest that oral steroids or systemic steroids will work. And in fact, towards the beginning of the global pandemic, the world's clinical olfactory experts convened to come out with a position statement, and they actually recommended that you exercise caution when you're considering oral steroids or systemic steroids, because it's really not standard of care in post-COVID smell loss. We just don't have enough data yet. And of course, corticosteroids can have some immune suppressive effects, and we don't want that to exacerbate any type of lingering COVID complications. The olfactory experts did recommend in their position statement that olfactory training be started as early as possible. What about topical steroid sprays? So again, this is extrapolation of data from prior to the global pandemic. So we're looking at other types of post-viral smell loss. There are 4 studies, again, non-COVID, but 1 randomized controlled trial, which was fluticasone spray, 6-month follow-up, 23 patients, and none of them showed benefit. There are 3 studies that were case series without control, and 2 studies showed some benefit with about 50 to 60% of patients improving. So there's not really great evidence that steroid sprays work prior to the pandemic. This paper did come out, however, and this is post-COVID smell loss data, randomized controlled trial looking at mometasone furoate. Mometasone is the active ingredient in Nasonex, and they looked at mometasone spray and olfactory training versus saline alone in olfactory training, and they found that the mometasone group demonstrated a 2 times more patients returning to normal sense of smell compared to the saline and olfactory training group. What about topical steroids irrigation? So that's a little bit different than the spray. The irrigations, you're actually putting the steroid into solution in a saline and actually washing or lavaging the nasal cavities, which may get a wider distribution of the drug. So again, this is not COVID data, but we have steroid irrigation and olfactory loss data prior to the pandemic. We've got randomized controlled trial, a nice study here that looked at olfactory training plus saline irrigation compared to olfactory training and budesonide saline irrigation. 133 patients, 6-month follow-up. There was a 27% improvement in the group that had olfactory training and saline, and actually a 44% improvement in the group that had budesonide added to their saline and olfactory training. So it looks like something, there's some signal to noise there, something going on, and no surprise, if patients were younger or they had a shorter duration of sense of smell, they had a better prognosis. What about dietary supplements and things of that nature? There's a lot out there on the internet. And we just don't have great data at this point, but we do know that COVID-19 is associated with increased TNF-alpha, as I mentioned in those previous biopsy studies. And there are multiple different supplements that we do know decrease TNF-alpha. So it raises the question, should supplementation with these help with the smell loss? So vitamin C, vitamin E, vitamin D, omega-3 fatty acid. We know that those decrease TNF-alpha. Just don't have great COVID-19 data yet. With respect to omega-3 fatty acid, as I mentioned previously, I do use it. I recommend it to patients. Why do I do that? And primarily it's because of this study here. So this is relevant to the type of the surgery that I do. It's a randomized controlled trial, 87 patients who had cellar and paracellar endoscopic skull base surgery. So that's using the nose as a corridor to go up to the skull base or into the brain and remove tumors. These patients oftentimes have transient and rarely, sometimes permanent smell loss. These patients were subjected to objective olfactory testing with the upsit at baseline 6 weeks, 3 months, 6 months after skull base surgery. And they were randomized to two different groups, just saline rinsing the nose after the surgery versus saline rinsing and taking oral omega-3 fatty acids, 1,000 milligrams BID. And they found that in the control group that didn't have the omega-3s, they had a 25% long-term smell loss, whereas the group that did take the omega-3s, that smell loss was down to 6%. So what about management in the primary care setting? How do we help these patients? Again, going back to that British Rhinologic Society, they really went out there and put a statement out to try to help primary care providers in the UK. And again, they recommend loss of sense of smell less than 3 months can probably be managed in the primary care setting. However, they do recommend you get those patients on olfactory training. If the sense of smell has been gone for more than 2 weeks, get them right on that olfactory training with the essential oils. Imaging is generally not recommended for patients with loss of sense of smell that is definitely associated with COVID-19 infection and has no other neurologic symptoms at presentation. There's a very busy algorithm here that I included in your syllabus. I'm not going to talk about it right now, but it's easy to walk through that algorithm to see how to manage these patients in the primary care setting and when an ENT referral is appropriate. And then just a summary here of a practical approach, which I think makes a lot of sense. So when we see these patients that come in with a history of acute viral respiratory illness, loss of sense of smell, test positive for COVID-19, or just present with loss of sense of smell, test positive for COVID-19, I want to work up and treat any other inflammatory rhinitis or sinusitis right away. Again, I just think of that's low-hanging fruit. It's technically straightforward to treat with topical steroids, and this might be a situation where I would give a patient oral steroids. So, for example, they have post-COVID-19 smell loss, they present, they have polyps. I'm going to treat that how I would normally treat polyps with corticosteroids if there are no other contraindications. Once I've got that out of the way, I talk to them about olfactory training. This all happens at the same visit, by the way, but I tell them this is what we're going to do, boom, boom, boom. So I get them all on olfactory training. I give them that handout, have them go get their 4 essential oils and start that right away, twice daily. I tell them about the functional MRI studies, and there's really something going on there. I get them all started on budesonide irrigations, which again, budesonide is a topical steroid, comes in liquid form. It's generally recommended as a nebulized therapy for asthmatics and people with COPD, but we have them put it right into their saline irrigations. You can also get it from compounding pharmacies across the country. We have them start that twice a day. I have them all start omega-3 fatty acids because it's safe, and again, it's been widely applied across the neural axis in various neuropathic conditions, and it can help. And then, I have them come back at 3 months and or 6 months if needed. So in summary, what do we talk about? Well, most patients who have COVID-19 do experience transient loss of sense of smell, whether they knew it or not. Fortunately, most of them get it back. Unfortunately, 5% of patients will develop a long-term olfactory dysfunction that lasts beyond 6 months. Olfactory training should be initiated in all patients, and I recommend saline and steroid rinses, nasal steroid sprays, and oral omega-3 fatty acids should be considered in this patient population. And then consider ENT referral for smell loss associated with other nasal symptoms or smell loss that's greater than 3 months duration. Or I would say anytime you have a question, don't hesitate to pick up the phone and call your ENT colleague or send that patient over. We're happy to help. Thanks.
There was a question that came in prior to the presentation. I think it would be an answer. How does COVID affect taste and smell, and does it return if affected?
Yeah, so good question. And just to review, SARS-CoV-2, the spike protein attaches to those sustentacular cells, the ACE enzyme on the sustentacular cells, and the proteases, ramps up the infection, destroys those sustentacular cells, which then impairs the ability of the olfactory nerves to work. We do know that about 50% of patients are going to report smell loss, if not more than that. 75 to 90% of patients, if you objectively measure it, have smell loss. So even if you didn't think you lost your sense of smell, there's a good chance you did. Fortunately, it's going to come back usually so 80% of patients are going to get their smell back within 3 weeks. 5% are going to have smell loss that lasts beyond 6 months. And again, all the things I mentioned: olfactory training, nasal steroid irrigations, omega-3s.
One more question. We're done with that one.
Okay.
What is the time of day of the nasal saline and topical steroids for treatment?
Good question. So I recommend twice daily therapy and, just roughly 12 hours apart. So I tell patients, hey, keep the stuff by your toothbrush. You brush your teeth twice a day, or hopefully you do. Do your nasal irrigations twice a day. So morning and evening.
She expanded examples: steroids first, then nasal saline question, BAD question.
Okay, so that's a good question. That's a very good question, because that's a person who's probably treating with a nasal steroid spray and saline irrigation, as opposed to putting the steroids in the irrigation itself. So if the steroids are in the irrigation, it's very easy. It's just all there in one, and you just do the irrigation, and you've rinsed out the nose and put the steroids in at the same time. But that's a very good question, practically speaking, because you'll want to rinse your nose first with saline, then put your nasal steroid spray in, so that obviously you don't rinse out your nasal steroid spray. Thank you.
Welcome back. Next, we're happy to have Anthony Veglia, who's a doctor of physical therapy, and Natacia Howard, who's a doctor of audiology. They work together in our Scottsdale Ear, Nose, and Throat divisions, obviously in Scottsdale, at the Dizziness and Balance Center. So they're going to talk to us about vestibular dysfunction, overview, diagnosis, and what they can do for it.
All right. So, as was said, I'm Anthony Veglia, and I'm a bit of a nerd. I got into vestibular rehab. That's kind of where I landed. So let's get right to it and make sure I know how to do this. There we go. First off, we're going to be talking about how the body actually takes in external stimuli in order to output balance. It's a lot more complex than just the automaticity we expect. A couple common vestibular disorders that you're going to see whether or not you specialize in this, whether or not you're an ENT or a PT. And finally, what are we going to do about that? So right off the bat, 3 sets of 3s. We're able to take in visual stimuli with our eyes. We are very prone to being able to line up with the horizon very effectively. Also seeing obstacles, so if there's any issue there, balance is at stake. Somatosensation, if that's dealing with mainly touch and proprioception. If I start to notice that I have more pressure on my left foot, I must be leaning that way. But maybe someone has neuropathy, they don't have a lot of sensation in their foot. My left quadriceps, for instance, might register more activity, so I'm also going to be able to tell that I'm going that direction. Finally, equilibrium sense or equilibrioception, talking the inner ear. We'll get back to that in a second. The nervous system, though, has 3 places that we actually integrate all of these. The cerebellum is dealing with a lot of the fine-tuning, and especially postural control. In order for my spine to stay upright, those muscles have to be operating just precisely so that I'm not tipping over throughout. My cerebral cortex is dealing with motor planning. If I want to lean to the left, I need to be able to get all of the muscles on board effectively. And lastly, the brainstem is dealing with a lot of the reflexes that are involved with the inner ear, the eyes, and the muscles. We're going to come back to that in the next slide. So the inner ear itself, right off the bat, if you don't have some little inner ear model and you are interested at all in vestibular rehab, this is something that I highly recommend. It's really great for visualizing how this operates. And just as a great anatomy overview, 3 semicircular canals that are dealing with the rotational movements of the head. They are not prone to any gravitational influence. They only deal when the head is actually in motion. The utricle and saccule, they deal with linear acceleration. You hit the brakes real hard, they're able to register that inertia. Utricle is dealing with anything transverse. Saccule is dealing with anything in a sagittal plane. And those 3 systems in the inner ear are able to register so much in terms of balance. and that's where a lot of things can go wrong. So the reflexes that we're talking about, if my inner ear registers any kind of motion and I'm looking at a random spot on the wall, my eyes are still able to take perfect aim at that target even when my head is moving. This is an extremely fast reaction. It's very automated, and gaze stabilization is a massive part of our balance. If there's any delay in this, we're going to feel disequilibrium because every time our head moves, we have to retake in the environment because our eyes didn't keep track. The VCR and VSR, vestibulo-colic and vestibulospinal reflexes, also take in the information from the inner ear, but they're dealing with it in a different way. They're two flavors of the same thing, really. But if I register a sudden head movement, my neck is going to be able to orient with gravity, and so is my spine. The cervico-ocular reflex is kind of the opposite end of things, and we're going to be talking about cervicogenic dizziness in a little bit. If my neck registers a movement, particularly in a side bend motion, my eyes are able to stay in line with the horizon so that I can see as effectively as possible, even though my head's moving. Lastly, the optokinetic response. If something does move across my vision, my eyes are able to keep track with it. Again, if there's any delays in this, if we start to experience choppy, saccadic movements, I'm having to retake in the environment repeatedly. That's not effective for keeping us upright. So if any of these reflexes or if anything's going wrong with the system, we're going to experience disequilibrium, dizziness. And to talk more about diagnosing dizziness, we have the wonderful Dr. Natacia Howard next. It's this little button.
Thanks. Hello. As mentioned, my name is Natacia Howard. I am an audiologist at Valley ENT, and I specialize in the diagnosis of vestibular dysfunctions. So what does dizziness mean to you as primary care physicians? Well, according to the CDC, dizziness is the third most common complaint heard in physician offices. Back pain is one of the most common. And how does this relate to ear, nose, and throat? Well, 85% of vertigo and balance dysfunctions may be inner ear related. There are a variety of tests used to diagnose vestibular dysfunctions, the first being audiometry. At minimum, it includes a tympanogram and a hearing test. A tympanogram is going to evaluate the middle ear, assessing for perforations in the tympanic membrane or fluid in the middle ear cavity. And a hearing test will look at the cochlea, the hearing organ. The cochlea and the balance organ are both housed within the inner ear. They function separately, but there are a few different vestibular disorders that can affect the two. So it's always nice to start out with the hearing test first. Video nasogography, as shown in the top picture. It's the gold standard for vestibular dysfunctions. It has 3 different subtests, the first being the ocular motors. Ocular motors are screenings for central pathologies. The third subtest is a positioning testing. That's primarily going to be looking for a condition called benign proximal positional vertigo. It also gives information on compensation for other inner ear pathologies. And lastly, we have the caloric irrigations of the VNG. That's one of the only tests that can give us information on how much the brain is receiving from the inner ears independently. So the brain should be receiving equal information from those inner ears, but sometimes with different pathologies, one's functioning too much, one's not functioning enough. The brain gets unequal signals and can result in some dizziness. Auditory brainstem response, it's an evoked potential, as shown in the bottom picture there. The patient is hooked up with electrodes and they listen to an auditory stimuli. For an ABR, we're assessing or looking for an acoustic neuroma, a tumor on cranial nerve 8. Electrocochleography is another evoked potential. It's assessing for a disease called Meniere's disease. The VEMP, the vestibular evoked myogenic potential, it's measuring the function of the saccule, utricle, and the superior vestibular nerve, which supplies those 2 organs, and is also a branch of cranial nerve 8. The next 2 tests, the video head impulse and the rotary chair, as shown in the top 2 pictures, complement the caloric irrigations of the VNG testing, but at different frequencies. Calorics are limited to a very low frequency of 0.003 hertz. VHIT tests super high frequencies, and the rotary chair tests all the frequencies in between, ranging from 0.01 to 0.64 hertz. These frequencies represent more real-life movements. Furthermore, the VHIT evaluates all 6 semicircular canals,
whereas the V&G and rotary chair are exclusive to the horizontal canal. Rotary chair is good for monitoring peripheral dysfunctions over time. It's also the gold standard test for diagnosing bilateral vestibular dysfunction. Next, the computerized dynamic posturography. It's in the picture on the bottom, is where the patient is placed in a platform and tested in a variety of different conditions. They're tested with their eyes open, eyes closed, with the surround possibly moving or staying still, or the platform beneath them moving. It gives information on how well the eyes, the inner ears, and the muscles and the ligaments in the lower legs work together to keep our balance. It's primarily used for diagnostic testing and treatment. However, it can start to detect some aphysiologic performance. Furthermore, most of our tests are objective, making it nearly impossible to fudge any of the data anyways. Lastly, in certain cases, imaging studies are ordered to provide more structural versus functional information. The pros to ordering vestibular testing first is the cost. So when we're looking at our images, for example, imaging studies can start to show an acoustic neuroma. We also have a test called the ABR that can look at that as well, and it costs about 1/10 of the cost of the MRI. It takes less time, and it's reportedly more comfortable than the MRI. A con is that the ABR is not as sensitive as the MRI. Next, I'm going to be talking to you about some of the vestibular disorders, not all of them, and these not necessarily are common, but they are well-known ones. First, the acoustic neuroma. It is a benign, usually slow-growing tumor that grows on cranial nerve 8. It's also known as a vestibular schwannoma. It affects about 1 in 100,000 individuals, and it usually presents with a unilateral hearing loss, unilateral tinnitus, and dizziness. Benign proximal positional vertigo, or BPPV for short, is the most common disorder of the inner ear. It's when the otoconia are dislodged from the gelatinous membrane within the utricle and become free-floating in one or more of the 6 semicircular canals. The most common cause of BPPV is head trauma when we're 60 years or younger. Somebody gets hit in the head and it literally dislodges those crystals from where they belong. But as we age, that membrane that the otoconia are housed in becomes a little bit less sticky, and the condition can become more prevalent with age. Bilateral vestibular hypofunction, that is when both of the inner ears are not functioning up to par. There's several different peripheral and central pathologies as listed that can cause this. However, 70% of people with bilateral vestibular hypofunction will complain of oscillopsia, otherwise known as bouncy vision. Cervical genetic dizziness is a dizziness that typically comes from the neck. Patients will complain of dizziness with different head positions or neck positions. Enlarged vestibular aqueduct is a malformation of the inner ear that occurs during fetal development. It always presents with the hearing loss and sometimes with dizziness. It's best to avoid head traumas with this condition as it can make it worse, so early detection is essential. Labyrinthitis and vestibular neuritis, they are inflammations of the inner ear. More specifically, labyrinthitis is the inflammation of the labyrinth itself, so it causes hearing loss and dizziness, whereas vestibular neuritis is inflammation of the nerve causing only dizziness. Maldebarkment, it's caused by exposure to a movement, then removal of that movement. So sea travel is the most common cause. However, it can also come from traveling by airplane, train, car, etc. It can even come from sleeping on a waterbed. Meniere's disease is when the inner ear retains too much sodium, not allowing it to function properly. Meniere's disease typically presents itself with 4 cardinal symptoms, the first being oral fullness, where the ear feels full, plugged up. Tinnitus, often described as roaring, almost as if a freight train. Fluctuating hearing loss, we typically see that in the lower frequencies as opposed to the traditional high-frequency hearing loss. Some days it's good, other days it can be bad. And then long-standing dizziness lasting hours at a time. Migraine-associated vertigo. Migraines in general are extremely common. They are more common than asthma and diabetes, and they're almost as more common as hypertension. 40% of migraine patients will have vestibular symptoms, and that doesn't mean that they need that a headache goes along with it. As we know, migraines can migrate, and if they're occurring near the vestibular system, they can present themselves with dizziness. Perilymph fistula, it's a defect that allows the perilymphatic fluid from the inner ear to enter the middle ear. This is especially true with different pressure changes, so coughing, sneezing, bending over, heavy lifting, fast elevators, airplanes, or even mountain passing. The patient typically presents with oral fullness, fluctuating or sensitive hearing, and dizziness. Persistent postural perceptual dizziness, triple PD for short, is a non-vertiginous, unexplainable dizziness provoked by environmental or social stimuli. It usually follows a pre-existing vestibular disorder. So for example, we may have a patient who has BPPV, we clear them of BPPV, but they still are feeling dizziness outside of the expected residual dizziness phase. They can get categorized in this disorder and get additional help. It also can follow like medical illnesses or psychological stress. Superior canal dehiscence. It is an opening in the bone overlaying the superior semicircular canal. It's going to present with conductive hearing loss and dizziness that's provoked by loud sounds or pressure changes, as I mentioned with perilymph fistula. People with this condition also complain that their voice sounds abnormally loud to them. So here's an example of just a portion of the testing, the V&G only. The first few tests are the ocular motors, the middle portion is the positional testing, and then the last part is the caloric irrigations. In this case, the patient had right beating spontaneous nystagmus. It did suppress with fixation, so that makes us start to think it's more peripheral versus central. She also had that static position, nystagmus as well, throughout all positioning testing. And she had a caloric weakness of 59% to the left. Anything over 25% for calorics is considered clinically significant. So when you put all three of those findings together, she is suffering from an uncompensated left vestibular hypofunction. So her left ear is not giving enough information to her brain. Although we were thinking more peripheral with this patient because her spontaneous nystagmus was suppressing with fixation, her ABR was also abnormal, so we ordered some imaging studies to rule out or confirm an acoustic neuroma. And next I'm going to be turning it back over to Anthony.
All right, you guys are stuck with me again. So this slide right off the bat is very busy. This is not something we're going to be going through in detail right now. This is a cheat sheet for later. If you are having a patient experiencing dizziness and you're not sure where to begin, maybe you don't have an awesome audiologist like Natacia who can diagnose with you, this is a great place to start, especially that keywords column there. Common complaint I hear, patients say, every time I get up to go to the bathroom in the middle of the night, I don't want to turn the light on and wake up my husband or my wife. So they feel incredibly unbalanced. If they don't have visual input, their inner ear should be able to compensate fairly well, but it's not. So I'm suspecting a vestibular hypofunction. That's where I'm going to begin. But again, you can check this out later. This is a lot all at once. Some quick notes. We're going to talk about treatment next, my favorite part of this. Age and gender do not have an effect on their potential for improvement. Now, that is not to say that those are not going to change therapy as a whole. 2 weeks ago, I had my 96-year-old lady who was struggling with her walker. That's very different than the 23-year-old who had a concussion and is trying to get back to competitive volleyball. But they both have the potential to improve. The brain is plastic, so we're not going to be discounting someone because they're older. In terms of central and vascular causes, we just mentioned concussion. Some of the central issues earlier in the slides, if you are having issues in those areas, like the cerebellum, that is certainly, balance is certainly something you want to consider. But we're not going to go into super huge detail there, but the treatments I'm about to mention do benefit those. I am not a provider who's able to prescribe medication. I'm a physical therapist, but that actually doesn't affect my patients too much. Long-term vestibular suppressants, so meclizine, for instance, are not conducive to long-term benefit. You're going to be shutting down the vestibular system to a degree, and in order to overcome chronic dizziness, for instance, you need the inner ear to be able to give correct output to the brain. So we do not want to have long-term vestibular suppressant usage. An exception would be something like Meniere's disease. You're going to go into phases of not too bad symptoms and severe days-on vertigo. During those days-on vertigo bouts, you're not doing vestibular rehab anyways. You need to suppress the symptoms, let them get back to a semblance of normalcy. And then during the non-vertiginous areas, that's when you want to start doing treatment, make sure they're not taking excessive vestibular suppressants. So the big one, everyone's favorite, BPPV. As was mentioned, those crystals get stuck in the wrong tube. And again, if you want to treat BPPV, get yourself a little model. If you can't visualize this well, this is a must. Most commonly, the utricle is going to send that crystal into the posterior canal. This is a right ear, for instance. The posterior canal, horizontal is next most common. Anterior is the most rare. I did just have someone yesterday with anterior, but it's not very common. The right side is 40% more likely to have BPPV than the left. That's because across all cultures and people typically sleep on their right side. There's some theorized reasons for that. But anyways, it can also be on both sides. I've seen a lot of PTs tripped up by this. If you have both sides experiencing BPPV, you want to fully clear a canal. So if it's on the left side, for instance, fully clear that, get it gone, send them home. Then they're going to come back, you fully treat them for the right side. You don't want to mix and match in the same day. It's going to be excessively symptomatic, and it's going to start to blur really good positive findings. The anterior and posterior canals on opposite sides are parallel, so anterior on this side and posterior here. So they're actually treated with the same techniques. You just need to flip the side. Horizontal gets its own because it's special. If you're not sure of the BPPV, which side it's in, which canal it's in, maybe it's resolving and there are maybe a few weeks out from initial onset anyways, we actually have a solution for that as well that we'll see in a bit. With all of these though, we need the crystal to get out of the tube. These are one-way paths. So if it's in the posterior canal, everyone knows the Epley maneuver. I'm going to show it in a sec just in case you don't. But I'm going to be dropping them quickly onto their back so that that crystal falls to the bottom and I'm able to get it out of the tube. If it's in the canal itself, the main tube, this is fairly straightforward. If it's in the cupula at the very end of any of the tubes, go figure, it's very sticky and adhesive. That crystal is going to be jammed in there. You need an even more vigorous approach. I'm not going to go in detail on all four of these, but these are the four techniques that I best recommend. The Epley is by far the one you're going to be using the most. Semont is if it is stuck in the cupula, you need to get really vigorous. Appiani is in the horizontal canal. And the Zuma, which we'll get to in a second, that is a horizontal cupula lithiasis. The biggest mistake I see all providers making with this, you need to be vigorous with the movements. An Epley maneuver, the first stage of it is the Dix-Hallpike test. It should never take more than 2 seconds because you need to physically move those crystals. If you take your time with it, you may not get them all in one clump. I've done all four of these techniques on patients into their 90s. I have never had a patient injured by it. Get some pillows ready, let them know exactly what's about to happen, prep them, and hang on to them well. Shouldn't be a problem. Every time you do change position with any of these, at least 1 minute needs to take place for settling the otoconia so that they're stuck or that they rest where they are and you can proceed. Lastly, for this slide, there is an older school thought that after a treatment like this, you need, I've heard 24 to 72 hours where a patient stays upright. There is no statistical evidence that says that that is actually needed and it's not going to prevent recurrence. In fact, it can prolong symptoms. We've mentioned 3PD earlier. Someone has a vestibular insult like this, and then they still have dizziness later, even after it's fixed. That's because they weren't receiving normalized inputs. Once I'm laying on my back again and it's normal, that's going to actually progress me faster to a normal positional tolerance. If I stay upright for 3 days, I've never done that in my life. I don't think it would be very comfortable for me, and the first time I lay back again, it's suddenly a lot of stimuli. The Epley maneuver, just in case you're unfamiliar, if you only learned one of them today, this would be the one. The vast majority of cases are going to be in the posterior canal, and it's not going to be a cupula lithiasis. Again, this would be an example where it's either the right side posterior canal or the left side anterior canal. And as you can see there, I'm dropping the patient back, I'm rolling them over, and I'm getting the crystal to fall back into the utricle. This is, again, I would say master it with a model, grab your friends. If this was in person, I'd have you all do it on the floor right now. It's a great technique to learn, but make sure you can really visualize what's happening if you want the best results. If you do have a horizontal cupulolithiasis, which is pretty uncommon, this is a technique, it is the least established what the best treatment is for it. This one was recently proposed in 2017. Zuma is just the person who came up with the model, so that's what I'm referring to it as. They didn't actually name it. I have had a 100% success rate with this technique, so I really recommend it. You guys can check out that research a little later. I'll have references at the end. So, for a whole lot of other diagnoses, they're all going to have their own flavors to therapy and vestibular rehab. Acoustic neuroma may require surgery, for instance, but all of these, in terms of overcoming dizziness, you're going to have the three basic categories of treatment. A gaze stabilization exercise deals with that vestibulo-ocular reflex. Again, if I'm looking at the camera and my head's moving, my eye should have absolutely no problem keeping track of it perfectly. If that's off, we need to address it. Habituation drills have everything to do with positional tolerance. Every time I lean forward to get into the kitchen sink, every time I lay down quickly, I'm getting dizzy. We need to address that. And then like 90% of my job, functional training. This is balance training specific to the patient to get them improved at those tasks. We're going to reduce the falls. We're going to reduce symptoms. So everyone at home can do this right now. You can stick a thumb up in the air and you're going to shake your head no. If your eyes are not able to keep perfect track of that, either you're going too fast for your current level, or you really should hang out with me sometime. But the point is that I have a fixed target. It can be a sticky note on a wall. It can be your thumb. It can be a pen. But you're going to move your head back and forth. It can be up and down. You can even get into diagonals. The range is not important. Or actually, it's almost deleterious. If I go too far, I'm losing it out of my periphery. So it's a small range. And we find out the patient's threshold. You can even use a metronome. If this is how fast I can go to get dizzy, I'm going to go just shy of that, and we're going to slowly bolster that. An ice skater, for instance, can spin 7 times in a second or more. I can't, but they can handle that by doing spotting. They're doing a VOR movement just fine. If it's getting impractically fast or they have a really high need, again, an ice skater would need to be able to do this very fast, you actually add in movement of the target. So now it's moving contralaterally to my head at the exact same time. Same principles though. I don't want a large range. I want to have a quick pace. And I find that threshold and build up from there. This affects way more than just vision though. They have found amazing things in research saying that it helps with postural control. It helps with basically any category of dizziness. So this should be a go-to for almost every patient I see. Habituation, this is all about increasing tolerance to position. This is an incredibly good example because it's also useful for BPPV, and it's really gentle for a patient that may not be as mobile. But I'm simply going to be sitting up, turn my head to one side, 45 degrees, so that I align canals, and I lay on my side. I spend 30 seconds there, 30 seconds upright, then I go the other way. You're repeating this for 5 minutes. The 30 seconds is the most important part. You can pick any position. Maybe, again, I've had a few people lately, they hate bending forward to get into underneath the sink. Then maybe I'm having them sitting and I'm tipping them forward for 30 seconds. We're convincing, with central compensation, we're convincing the brain, it's okay to do this. It's okay to be in these positions. We normalize this, and you can build up speed from there. Then the really fun part. There is an infinite number of exercises you could fit into this category, but functional balance training. A patient has vestibular hypofunction. Their inner ear is simply not giving enough information to the brain. Okay, so I'm going to take away your sense of touch by doing that on the foam pad. I have my feet together, so it's a balance challenge, and then I restrict your visual input. If I can't maintain this, then I may need to go a little easier, but now I have nothing to keep me upright, nothing to determine postural control except my inner ears. That's how we develop central compensation so that they can balance. I've done that exact picture on the right there with patients much older than you might expect, less sturdy than you might expect, but it's a great place to begin. I'm going to keep it safe. I'm going to have a gait belt on them. I'll keep them in the corner. Especially if I give it for homework, they're going to be standing in a corner so that they might just bump their shoulder instead of a fall. But we need to get the brain to listen to the actual vestibular inputs or outputs. The other category would be vestibular overload or vestibular challenges. Instead of restricting, so I only have the inner ear, I give them their sense of touch, so flat ground. I give them their vision, but now I'm just rapidly increasing how much vestibular input they have to deal with. If they can't maintain balance while having all this input, that's going to be the issue. So we build up from there. Again, I could combine these. I could do this walking. I could have people walking backwards with their eyes closed, with head turns, whatever the patient may need, but this needs to be personalized training, and it's a vast part of my job and one of the reasons I really love it. All right, so that was for treating a whole lot of different things. Most cases of dizziness, this is where we're going to go. Some other conditions, though, so cervicogenic dizziness. I've personally known a few PTs and a couple PCPs that were struggling with cervicogenic dizziness. We already know that there's reflexes to and from the neck that deal with the vestibular system. Especially if there's unilateral neck pain or neck dysfunction, they're getting a different timing for their afferents. That's going to cause me to feel really unbalanced. So first and foremost, just treat their neck. I've had patients in the past where all I did was start their neck treatments and the dizziness reduced. If it's been chronic especially, you may need to address other things, something like a VOR exercise. It's also working their neck a little bit, so you can certainly include that. But really think about it as neck pain first, get into the dizziness later. The last few things. So if someone does have something like a superior canal dehiscence and they do a surgery that fills it with bone cement, they no longer have a superior or anterior canal on that side, so the opposite side, posterior canal, has to handle that plane alone. Similarly, if someone has a vestibular nerve section or a labyrinthectomy, they are absent from vestibular inputs on that side, so the other side has to do all the work. A really fun way to do this is to stick an eye patch on the uninvolved side. Now that remaining side, they don't get any input visually, so vestibular sense has to be dominant. And again, make it very personalized. Lastly, mal-day debarkment, mentioned before. They go on a cruise, they come back, they're still on a cruise. They still feel like they're at sea. This can last for, I've had a patient with it 9 years later. This is not a super well understood diagnosis. There's a lot of questions about it. It almost exclusively comes to patients with a pre-existing anxiety or depressive disorder. For some reason, it's 9 times more common in women. We don't have a lot of questions, or we have a lot of questions, we don't have a lot of answers. This is extremely personalized. I literally make a list. Here are the specific positions and things that this patient can't tolerate, and that's pretty much all we hit. So those are some less common treatments, but that's a basic overview of what a PT does for vestibular rehab training. If anyone ever has any questions, please get in touch. I'm at the Scottsdale ENT branch of Valley ENT. And like I said, I'm a nerd, and I would love to answer any emails or anything about it, or send patients my way if you really feel they could benefit from it. A lot of these conditions, VRT is known to be more effective than medication, so I'd love to help out any patients I can. Thank you very much. Yeah.
Okay, finally, I'm happy to introduce Adam Cassis. You already know him. Special thanks goes out to him for being our course director this year. Today, he's a house-trained, which is the mecca of ears, neuro-otologist, and he's going to talk to us about sudden sensorineural hearing loss, which is a true medical emergency, but doesn't always get as much airtime as it should. So, thanks, Adam.
Thank you, Dr. Hurley. It's my pleasure today to talk about sudden sensorineural hearing loss. As Dr. Hurley mentioned, it is a medical emergency because the ramifications of a hearing loss can sometimes be long-lasting and life-changing. From an anecdotal perspective, I think there's probably an increase in the incidence of a sudden sensorineural loss during this time of the pandemic, maybe due to the ongoing viral load that we see in the community. I have, over the years in my practice, seen some inappropriate treatment and referral patterns for this particular process, And that's the main driving factor why I'm here talking to you about it today. I have no disclosures. So the objectives from today's talk, first is to identify the impact of a sudden sensorineural hearing loss. As you can imagine, the sudden change of one of your senses can be life-altering and quite anxiety-provoking, especially if you had that sense the day before. Recognize sudden sensory hearing loss in your clinical setting. Discuss the ear exam and how it applies to this process. And finally, discuss appropriate treatment and referral for these patients. So before we begin, let's review the ear anatomy. So first, our external ear, which is the pinna in the ear canal, the middle ear, which is the eardrum and the ossicular chain or bones of hearing in the middle ear space, as well as the inner ear with the nerves that carry that information to the brain. So the way the ear works, sound will travel through the ear canal, vibrate the eardrum, then the bones of hearing, which sends a fluid wave into the inner ear. Within the inner ear, there's little nerve endings, which we call hair cells, that capture that fluid wave, convert that into an electrical signal, sends that message along the nerve to the brain. And it's really the inner ear that's affected for a sudden sensorineural hearing loss. So what symptoms might a patient present with when they have a sudden sensorineural loss? Most common is going to be a sudden or abrupt onset of hearing loss, usually in one ear, sometimes in both, but 95% of the time or more, it's going to be just in one ear. Often will be accompanied by ear fullness or a sense of fluid in the ear. Tinnitus or sound in the ear is going to be almost universal for these patients, and vertigo is also quite common, seen in over half the patients. Sometimes you'll get a history where there was a preceding viral or upper respiratory illness. Well, what might a patient say when they come in complaining of a sudden or having a sudden sensorineural loss? So most patients will typically say, I woke up and I can't hear, or I felt a pop in my ear and then my hearing was gone. Or it feels like I have water in my ears and it needs to pop and needs to drain. Sometimes when patients say this, it really throws off the practitioner because they're expecting to see fluid in the ear, and maybe that's where they get some tunnel vision. They're unable to think about what else might be causing this patient's symptoms. Or all of a sudden I had a loud ringing in my ear and it's hard to hear. All of these complaints can be combined with some vestibular symptoms. Oftentimes the patients will complain of vertigo or the world spinning around, they're sick, nauseous, vomiting. So there's a significant healthcare burden associated with a sudden sensorineural loss. The incidence is about 66,000 cases per year. It's likely more than that, mainly due to the patients who self-resolve over time. This is going to result in many healthcare visits, often for the initial episode, but maybe the patient's been misdiagnosed, they're seeing multiple other folks, and maybe when they do go to see the appropriate physician, they're having multiple clinic visits to treat that episode of hearing loss. Oftentimes, as I mentioned, there's comorbid dizziness and tinnitus. Dizziness, as I mentioned, is quite common, may have lifelong and long-term symptoms associated with that. So not everybody does that dizziness completely resolve. Likewise, with tinnitus, as you see in almost all patients, and this may be the predominant symptom in a lot of these folks. And we know that tinnitus can have a significant economic and psychologic impact to the patient. Typically, the tinnitus will improve if we're successful in improving the patient's hearing. And that's why improving hearing in these patients is vital. What kind of problems do you see with a unilateral one-sided hearing loss? Obviously, the patient can't hear from the affected ear, so we have what's called a head shadow effect. So if my left ear is deafened, sound coming in from that left ear will be blocked by my head from getting to the right ear. So the inability to hear anything, especially with potentially dangerous sounds coming from that side, say an oncoming car if you're crossing the street. The brain is designed to have two ears, so your ability to localize sound is going to be impaired if you have hearing loss in one ear. Also, hearing and noise. The brain is used to having signal from both ears. It's able to take both that signal to help null out the background noise. If you have hearing loss in one ear, your ability to do that will be greatly reduced. Any of these symptoms will be greatly compounded in folks with pre-existing hearing loss. We do tend to see this in an older population, although it can really affect any age. But if you have pre-existing hearing loss, these problems with the unilateral hearing loss will be much worse. and generally decreasing your quality of life if you lose a sense all of a sudden. So what causes it? For the cases that are occult or we don't really know what's going on, there's a few things that we think might be causing it. First is a viral type of infection, just because some of these patients may complain of a viral type of illness prior to their hearing loss. Likewise, there's a possibility of a vascular cause, meaning a rupture of a blood vessel within the inner ear, some sort of spasm of the blood vessels going to the inner ear, or some sort of clotting mechanism as well. There's not a test to tell us if it's viral or vascular. Likewise, autoimmune conditions can sometimes cause a sudden onset of hearing loss, and these are the folks who will tend to get it in both ears, but this is quite uncommon. Also uncommon are retrocochlear lesions, acoustic neuromas, meningiomas, anything that might affect that nerve going from the inner ear to brain may cause a sudden hearing loss. However, 9 times out of the 10, when patients come in for their evaluation, we're not really sure what exactly caused that individual patient's sudden hearing loss. Now, there are some causes where the trigger is clear, noise-induced hearing loss or some sort of pressure event or barotrauma that the patient experienced. Sometimes ototoxic medications, antibiotics, chemotherapy agents, certain diuretics can cause hearing loss as well, and sometimes it occurs suddenly. So how do we evaluate a patient with a sudden hearing loss? The typical history for a patient with a sudden sensorineural hearing loss is the onset of less than 3 days, although it's typically overnight or all of a sudden. There's really big 4 otologic symptoms you should ask anybody with any ear complaints. That's hearing loss, tinnitus, fullness or pressure sensation in the ear, or dizziness. Those first 3 are almost completely universal for patients presenting with a sudden loss, although dizziness is fairly common as well. You're also going to want to inquire about focal neurologic symptoms as well. You don't want to miss the patient coming in with an acute stroke with a hearing loss as well, so you definitely don't want to miss that. For the physical exam, it's really going to be focusing on the ear exam, what the ear looks like, and we'll talk about the tuning fork exam, which is really going to be vital, and one of my main goals of this presentation is to instruct on the tuning fork and really how important that is in your setting in evaluating these patients. Again, a neurologic exam, you don't want to miss the patient with a stroke. So in order to know what's going on with the ear, you have to know what a normal ear looks like. So this is a picture of a normal ear. As we can see around the edge, that's the ear canal. Centrally is the tympanic membrane, typically looks like looking through wax paper. The structure you see resting against the eardrum is the malleus, the first bone of hearing. Again, there's no fluid or any type of disease process going in behind the eardrum that we can tell. And so the majority of patients with a sudden sensorineural loss, this is what your ear should look like. It's going to look normal because it's not an external ear or middle ear problem. It's the inner ear, which you can't really see. The only way to see the inner ear is to image it. However, if you do have a patient with some scarring of the eardrum, so forth and so on, that does not rule out a sudden sensorineural loss. Chronic ear disease is so common. So a lot of patients walking around with some minor abnormalities of the eardrum that may be throwing you off. So you still have to consider a sudden sensorineural loss, even if your exam is slightly off. However, I do want to go over some relevant otoscopy findings to help better evaluate these patients. So first is simply a cerumen impaction. Cerumen can look any different shade of orange, yellow, brown, different moisture levels. So on the left there, that's a typical cerumen impaction, completely occluding the ear canal. That wax needs to be cleaned. On the right there, you see a picture of otitis externa. The skin of the ear canal is slightly swollen, it's red, there's debris there. Likewise, foreign bodies, anything that can go in the ear probably has. Dirt, rocks, toys, beads, what have you. Also, different animals and critters don't mind crawling into your ear from time to time as well. Likewise, tympanic membrane perforation can be seen. It's not too uncommon. So on the left there, it illustrates a small perforation of the eardrum. However, on the right side shows a near complete perforation of the eardrum. And this is where it gets a little bit tricky, is diagnosing otitis media. I can tell you when I was a medical student, I had a very difficult time telling you if there was fluid behind the eardrum or not. Even in my 4th year, after 2 rotations within an ENT department, I still had trouble. So it really takes some time. So I implore everybody when they're coming in, look at your patient's ears so you kind of know what normal looks like. When you see abnormal, you kind of know it when you see it. So otitis media on the left, this is a purulent, thick fluid built up behind the eardrum, but the eardrum itself is intact. On the right there, you see otitis media. However, there's a hole in the eardrum. There's drainage coming from the middle ear into the ear canal. Now, this is otitis media with effusion, so less of an acute appearing ear on the left. So you can see an air fluid level. Below that is an amber-colored effusion within the middle ear space. However, on the right side, you see the middle ear that's completely full of fluid. So if you didn't know any better, you may just assume that that's a normal ear. However, the eardrum still looks a little bit dull. I know in the textbooks we're told to look at the cone of light. However, there's a completely full middle ear with an intact cone of light. So you really can't use that with any semblance of accuracy to diagnose middle ear fluid. Likewise, you can see fungal infections. Fungal infections are common here in the valley. You can see spores and hyphae. It can be white, black, really any color. And this is our final finding. And so when you see a patient coming in with this finding, you can see the eardrum. However, there's this big patch of white against it. That is not fluid. That's not infection. That's tympanosclerosis, really scar of the eardrum. That could have occurred from previous ear infections, trauma, perhaps that individual had a tube within their eardrum previously. And so if you see a patient coming in with that exam complaining of symptoms with sudden hearing loss, you still will have to consider that in your differential. It does not necessarily mean that that patient has a middle ear problem going on at that time. So again, the other important part of the examination is your tuning fork exam. And I'm going to go over this, but those watching at home, please, you'll need to review this just to make sure you know exactly how this tuning fork exam is conducted. It's not complicated and will pay you dividends many, many times over. So the first part of the tuning fork exam is the Weber. It's what we call a lateralizing exam. So what we do is we'll get a tuning fork, and it has to be placed, or really should be placed on bone. The thinner skin area, the better. Either the mid-forehead or over the nasal bridge, over the nasal bones. You'll want to use a 512 Hertz tuning fork, okay? They're $10 on Amazon. If you do not have one of these, you need to go get one. Order one today after the conference is over. Don't use a 256 tuning fork that you use for neurologic exams. They don't work for this. Again, you want to strike this on either your knee or your elbow to get the appropriate tone, not on any piece of furniture. It doesn't hurt. When you place that tuning fork into the patient, you ask them which ear they hear it in, louder or stronger, right, left, in the middle, or they can't tell. So we say this lateralizes. So how do we interpret the finding from this test? So if the tuning fork lateralizes to the affected ear, the ear that they have hearing loss on, that would suggest a conductive loss, which would be a problem within the ear canal or the middle ear, possibly fluid or any other middle ear cause. If it goes away from the affected ear, that's more in line with what we call with a sudden hearing loss or a sensorineural hearing loss, which is what we're talking about today. So again, there's a right way to do it and a wrong way to do it. As I said, you can place it on the mid-forehead, which is easily done. You can see that demonstrated here on the left. In the textbooks, you'll see what's demonstrated on the right. This is wrong. It does not work. Don't do it. The second part of the tuning fork exam is the Rehl test, and I would argue this is the most important part of the tuning fork exam, although we like to combine both the Weber and the Rehl test together. Again, we're going to ask the patient which is louder, behind their ear or in front of the ear, number 1 or number 2. First, you'll place that tuning fork onto the patient's mastoid, behind the ear, the thin-skinned area right behind the ear. That will be number 1. After they hear that tone, you'll immediately move it out in front of the ear, about 2 inches away from the ear canal, with the top of the tuning fork being in series, meaning pointing in a line towards the top of the ear canal. And they'll tell you which is louder, number 1 or number 2. Again, you're going to use the same 512 Hertz tuning fork. So what does that mean? If they hear it louder behind the ear than they do in front of the ear, that's consistent with the conductive loss, middle ear fluid, not a sudden hearing loss. However, in the affected ear, if it's louder in front of the ear than it is behind the ear, that's either the normal condition or it's a sudden hearing loss or a sensorineural hearing loss into that ear. Again, for the Rehl exam, there's a correct way and an incorrect way to do it. As I mentioned, you place it behind the ear and then in front. But on the wrong section here, there's two things that's wrong. One is he's using the wrong tuning fork. That's a 256 hertz tuning fork. And two, he's holding it so the tuning fork is parallel. So that sound is being jettisoned towards the ceiling of the room and not towards his ear. That's incorrect. So as I mentioned before, the René part is a portion of the tuning fork exam is the most important. There's a 91% accuracy in determining conductive versus sensorineural loss in non-expert users. So if you only use the René test in the affected ear, you could pick up most of the sudden losses that come into your clinic. One caveat is the patient is completely deafened in the affected ear. When you do the bone conduction test, placing it behind, it may in fact cross over to the normal ear in profound losses. But of course, if you did that, they may tell you that they hear it in their other ear rather than the affected ear. So again, if you learn nothing else from today, take home these messages. So otoscopy with proper tuning fork exam, you're going to capture the lion's share of sudden hearing loss. This is going to help you guide appropriate therapy and referral. If we do this, we can reduce the morbidity associated with sudden sensorineural loss with delayed presentation, which is the main issue that we see with a sudden sensorineural hearing loss, is the delayed presentation to our clinics. When in doubt, refer to ENT. So what's the workup that you should be doing? Stroke workup if indicated. However, there's no real other workup that's indicated at that time. Labs are not indicated for a sudden hearing loss. CT scan is not indicated for a sudden loss unless you're using it as a stroke workup. However, when we see the patient, we're going to do a full history physical, comprehensive audiogram, oftentimes order an MRI scan. So one of the most common misdiagnoses that we see associated with a sudden sensorineural loss is the ear infection, otitis media, ear fluid, eustachian tube dysfunction. So why is there this confusion? Well, oftentimes, the middle ear or ear infection, eustachian tube dysfunction, may be brought on by a preceding URI or sinus infections or allergies, very similar to a sudden sensorineural loss. The symptoms are nearly similar: hearing loss, fullness and pressure, perhaps a sound in the ear. Dizziness tends to be less common, but can be seen from time to time. It can also be rapid in onset. And again, otitis media is quite common, tends to be a little bit more common in children, but you can see it in adults as well. So why is this a problem? This misdiagnosis will lead to use of therapies that are just going to delay the treatment and are not going to be effective. So antibiotics, decongestants, nasal sprays, and likely an inappropriate dose of steroids. None of these treatments are going to help with sudden hearing loss. So to further illustrate this, I'm going to present two patients, one with an otitis media, one with a sudden sensorineural loss. You can kind of see where the confusion may lie and what we can do and how we can determine which is which. So the first patient, Harris, is a 50-year-old male, otherwise healthy, sudden onset of hearing loss, right side 1 week ago, recent head cold. Ear feels full, has sound in the ear, minimal dizziness. Julius, his counterpart, is a 75-year-old male, much less healthy, wheelchair-bound, multiple medical issues. Sudden onset of hearing loss in the right, about a week ago. Again, recent head cold. Ear feels full, has sound in the ear. Severe vertigo, but starting to subside. So what do we see on exam? And if you ask me, I don't see a whole lot of difference between these two pictures. There is a difference, in fact, but from the layperson's eyes, and when I was a fourth-year medical student, if you showed me these two pictures, I'm not sure if I'd be able to tell you if one was normal or abnormal. So ultimately, this patient boils down to the tuning fork exam. Again, why I think this is so crucial to understand how to perform a tuning fork. So Harris, his Weber will lateralize to the affected ear, the right ear. That's what we see with the conductive hearing loss condition. Likewise, with the René, he heard it louder behind his ear, which is number 1, as opposed to in front of the ear, which is number 2. That, again, indicates a conductive loss. His left ear was the normal condition. So the diagnosis would be a conductive loss on the right based off the tuning fork exam. However, Julius is Weber to the opposite ear, the left ear, the opposite side. Again, with his René tuning fork exam, he heard it in the normal condition, which is louder in front of the ear than behind in the ear. So the sound conduction mechanism is normal. And so his diagnosis from his tuning fork exam is a sensorineural loss on the right. So ultimately, Harris had the otitis media with effusion, and the Julius had a sudden sensorineural hearing loss. And so it can be a challenge to differentiate between the two. Because of the similar symptoms, sometimes the exam is not clear. So you really need to utilize not only the history, physical findings, but your tuning fork exam as well. So how do we treat these patients? So at the primary visit, when the patient's coming in to see you, I want you to think of only one thing: steroids, steroids, steroids. And this has to be a high-dose steroid. We like to treat the ear with at least 60 milligrams of prednisone daily, hopefully for at least a week, at least carry that patient over until they can be evaluated in our clinic. Prescribing a Medrol dose pack is like bringing a water gun to a forest fire. It's not going to work. If you're unsure if this is an otitis media with effusion or a sudden hearing loss, again, give steroids. It's going to help both conditions, but you have to give that patient an adequate dose of steroids in order to help them. However, if the patient has a contraindication to oral prednisone or other type of steroids, this is an emergency ENT referral because we have another treatment with an intratympanic injection of steroids that may be able to benefit that patient. Antibiotics don't help, and there's very little evidence that antivirals help. So when do you refer these patients? Anytime you suspect the patient has a sudden hearing loss. If you're unsure, refer that patient. Really, the referral should be urgent. So any patient with a sudden hearing loss should be seen as soon as possible. Same day, next day, definitely within that week. Considering the number of Valley ENT offices throughout the Valley, there's no excuse for us not to be able to see these patients within a week. So please keep that in mind. Again, when you're referring to ENT, you should state the emergent nature of the complaint. So having the patient call for a referral is inappropriate, or things like sudden onset of ear pressure or ear fullness, simply describing the patient's symptoms will delay that patient getting into the office. I would actually go as far to say you should personally follow up to ensure the patient was contacted and scheduled for an evaluation, because this is an emergency for that patient. So what do we do during the ENT visit? First, again, we're going to do a full history and physical evaluation. Again, we'll also perform tuning fork testing. The patient will go on to have a comprehensive audiogram with a tympanogram. If we do arrive at the diagnosis of sudden hearing loss, there's a few different types of configurations that we can see over the audiogram that we'll go over. But essentially, we use 30 decibel loss over 3 consecutive frequencies. However, clinically, we use less stringent criteria. We usually combine what we see on the audiogram base with the patient's symptoms. Oftentimes, we're comparing to the other ear to see if there's been a change in their hearing. So this is one audiogram configuration. At that chart there, at the top of the chart is the normal range, and the further down you go, the worse the hearing. So the blue X's are the left ear within the normal range, and you can see the right ear has a flat loss along all frequencies, or towards a mild range. However, you can see this configuration as well, where it's more low frequencies to the left of the chart, and the higher frequencies are normal. However, you see some patients where their ear is all the way at the bottom of the chart, where they have a profound loss. So again, we're going to treat these patients with high-dose oral steroids, 60 milligrams, anywhere from 7 to 14 days, sometimes with a little taper. However, there is an alternative to oral steroids, and that's an injection of intratympanic steroids into the ear. We use this in a few different situations. One, if the patient fails oral high-dose prednisone. 2, if the patient cannot tolerate oral prednisone, brittle diabetic, or other conditions. Or in the patient, as we previously showed their audiogram, if they have a profound loss, oftentimes we'll do both at the same time, oral prednisone plus the injection of steroids. Also, we tend to order MRI scans of the inner ear. I don't think you need to order that. Allow us to order that scan because it's a particular internal auditory canal scan with or without contrast. And so basically what we're looking for is any lesion within the inner ear, retrocochlear lesion. So this MRI scan here is demonstrating an acoustic neuroma of the left ear, and sometimes these tumors present with a sudden hearing loss into the ear. So what's the prognosis for these folks coming in? So there's a category of better and worse prognosis. So you have a better prognosis if you're younger, you don't have dizziness, you have a mild or low frequency loss. All of those factors the patient has no influence over. The only thing that they can influence their prognosis is a small gap between onset and treatment. And this is where we want to make an impact from today's talk. Likewise, with worse prognosis, the older patient, those with vertigo or severe loss, those that have diabetes, hypertension, or sloping or flat loss. And again, the only thing that patient or us as practitioners have an influence over is the potential large gap between onset and treatment. So for instance, if a patient has a hearing loss on day 1, and then I'm seeing that patient 2 to 3 months afterwards, that ship has failed. That ship has sailed. We want to treat these patients as soon as possible. The first week or 2 weeks is really the time where we have to make an impact, and the longer we go from that point in time, the less likely we are able to help that patient with their problem. So finally, when patients come in to see us, they'll have their final audiogram about 3 months after the onset of their hearing loss. If their hearing loss is restored at that time, no further treatment is necessary. However, if the patient does have some residual hearing loss, especially if tinnitus persists, we will discuss hearing aids with that patient if feasible. However, some of these patients will have severe to profound hearing loss, and hearing aids may not be helpful to them. So we do have some other options for them. This is a pair of what we call cross aids. It basically looks like a hearing aid for both ear. It'll act like a microphone on their bad ear, route that signal over to their better ear, so it helps relieve that head shadow effect that we talked about before, where the head is blocking the sound. Likewise, there is a bone conduction implant that will vibrate the bone of the skull and route that signal from their bad side to their good side. Again, this device here is fit completely underneath the skin with that small external sound processor, that black sphere device that you see there. And more recently, the FDA has approved cochlear implantations for those who are deafened in one ear. This is the only way to restore hearing into the deafened ear. However, we want to try to avoid this if at all possible, because cochlear implants do not restore normal hearing, and if at all possible, we like to restore their hearing with medicines rather than a surgically implanted hearing device. So to leave you with a few practical points here, for sudden onset of unilateral ear symptoms, I want you to suspect a sudden hearing loss in your differential diagnosis. Please learn your ear exam, and please learn the tuning fork exam, and if you don't have a tuning fork, please go buy one. They're $10. Treat with high-dose steroids if you know or you're unsure. And again, the referral for these patients with a sudden loss cannot wait. It's an emergent nature. So I appreciate everybody's attention today for our talk. And no questions. Okay, no questions. And so with that, I would like to conclude our ENT update for the primary care provider. Again, it's been my pleasure to present this course to everybody streaming at home today. I hope you found it a useful resource, and we look forward to continuing this conference for years to come. Thank you, everybody.